know her, but I had enough patients that had went through her and been like, she knows.
Okay, we're gonna go ahead and get started.
There was a couple other doctors that we recommended as well, but like, they had maybe, as QMPs, maybe made a little bit of people.
We need to get a gavel.
Yeah.
We call this meeting to order. Just a reminder, we have a much smaller room than we usually do, so please keep any side conversations to a minimum. We appreciate everyone coming. And I believe we started recording, correct? Okay, so the meeting is being recorded. This meeting is being held virtually and is hosted by the Utah Department of Health and Human Services, Center for Medical Cannabis based in Salt Lake City, Utah. Public notice of this meeting was provided as required under Utah's open meeting laws and was posted on the Utah Public Notice website. In compliance with Utah's open meetings law, this meeting is being recorded. A recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. A rough draft copy of the unapproved written minutes will be posted to the Public Notice website within 30 days of this meeting. Approved minutes will be posted to the Utah Public Notice website no later than 3 business days after board approval. As you all know, this is the Medical Cannabis Policy Advisory Board. You can see on the screen who the members are, as well as the HHS and UDAF staff that are in attendance. Just want to go over again our the instructions for public comments. We have had, a couple of changes that we'll go over. Just want to make sure everyone's aware of these. So public comments, whether in person or virtually, will be limited to 2 minutes per person. If you would like more time, you must request it from the board chair, and the chair may accept or reject requests for additional time. The public comment period is not guaranteed every meeting. The chair has the authority to create or remove public comment period from the agenda or during the meeting. You can look over public comment guidelines that are posted on the Utah Public Notice website. When making a comment, please state your name and your affiliation, so it can be reflected in the meeting minutes. Only comments made on items listed on the agenda will be considered. If you have a comment about an item not listed on the agenda, please email them to MCPAB@utah.gov. When making comments online and how to make a comment over Zoom, the Zoom public chat will be disabled during the meetings. And if you want to make a comment, you will need to fill out the comment registration form that can be found on the public notice website and is posted in the agenda document. The chair will indicate when it's time for a public comment period and will determine when it is your turn. You will then be taken off of mute. You'll have 2 minutes to make your comment, and the chair will then decide whether to take additional comments other than those who filled out the public comment registration form, and you will use the raise hand icon on Zoom to indicate that you would like to make a comment. For making in-person, comments, please sign in. There's a sheet at the end of the table here. If you do plan to make a comment at any time during the meeting on any of the issues, please fill out that form now, instead of having to sign in when you go to make your comment, to save some time. Of course, I will indicate when it is time for public comment, and will allow you to come and comment as, based upon the order and the list, or based upon the issue that you want to comment on. You will have 2 minutes to make your comments. This is one thing I reminded you all at the beginning of the meeting, but I'll say it again as a reminder. If you're in person, please do not speak when others are presenting. The mics are very sensitive, and those attending over Zoom cannot hear when there is more than one person talking at a time. Side conversations and comments from the public during this board meeting are prohibited. Same goes for board members and folks at the main table. If there's any need for side discussion, please wait until after the meeting, for whatever reason. Okay, with that, I think we can turn to the agenda itself. We've already welcomed everyone. We've already gone through kind of the rules of the road. Has everyone on the board had a chance to review the minutes for last month's meeting?
Yes.
Were there any changes or anything anybody would like to mention in particular?
I move to approve the September 2023 minutes as presented.
Okay, we have a motion to approve the minutes. Do we have a second?
I'll second it.
Abby, will you take the roll call vote, please?
Yes, J.E. Britton,
Yes.
Matt Page,
Yes.
Nanette Morenzi,
Yes.
Des Hennessy,
Yes.
Jimmy Hicks, who's not here, Ken Anderson,
Yes.
Misty Smith,
Yes.
and Annalee Keating.
She's actually just messaged us that she can't get on the Zoom link, but she's trying to, so I'm gonna send her the Zoom link.
You should have them about
Yeah. Okay, I find that motion passes unanimously. Okay, on to item number 3. This is administrative business, which we've really already covered. This is really to just talk about the registration form to make comments. If you're online, please use the form as identified, and you can link to it from the agenda. So please do so. Please reach out if you have any trouble being able to do that. So I think that's all the administrative business we have. I'll now turn it over to DHHS and UDAP for any updates from them.
Great, this is Rich O'Born, Director for the Center for Medical Cannabis at Utah Department of Health and Human Services. And one update is that the transition to a new medical cannabis software that is ongoing right now. We're in the midst of the project. Obviously, the configuration and development project phase is on track to continue until February. And then at that point, it'll shift to testing. And we do expect to go live with the new system that'll be built on the Salesforce platform in the second quarter of 2024. So that is an update regarding that medical cannabis software project. Also, Dr. Matt McKiff, he's the contractor we've hired as a physician that represents the Utah Department of Health and Human Services in public presentations. And he was able to do a presentation to the University of Utah Program for Addiction Research, Clinical Care, Knowledge, and Advocacy, otherwise known as PARCA. And so this program up at the University of Utah hosted this virtual presentation that Dr. McKiff was able to do to that group, and it included an introduction to medical cannabis therapy, the endocannabinoid system, treatment basics, and evidence-based guidance. And he also talked about the role of cannabis therapy, as well as the awareness and perception of treatment within the state's medical community. And so that presentation was done on October 3rd. It was well attended. It was virtual, and we were glad that he was able to do some outreach for DHHS at that point, but also the entire program and to help with knowledge about medical cannabis treatment and some of those basics that I think no matter how much we focus on outreach, there's always more we can do. So he was able to hit the needle just a little bit more, I think, in that presentation and move it toward more education and awareness about medical cannabis treatments that are evidence-based. So that's an update on that. And also currently, well, as of the end of last month, as of the end of September, there are 72,800 active medical cannabis cardholders in the state of Utah. Also, there are 970 QMPs. And of those, 19 are brand new, who've joined the program for the first time. Also, there was a Cannabis Research Review Board meeting that occurred on October 10th. And at that meeting, the Cannabis Research Review Board voted to approve some updates to the MS guidance document based on some new studies and research that they were able to incorporate into that document. So that'll be updated soon on our website. And they are also considering narrowing the scope of some of the debilitating persistent muscle spasms guidance document. And so that update is ongoing. Also, the pharmacist that we've hired to act as a contractor in gathering some of the research that's available about medical cannabis, Lauren Heath. She's employed by the University of Utah. But she presented her clinical research at the meeting related to the use of medical cannabis to treat Crohn's and ulcerative colitis. So if anybody's interested in listening to that, these are public meetings, and so you could listen in to that prior presentation. And we did ensure that those providers that have recommended to patients that have their qualifying conditions as Crohn's or ulcerative colitis, those were all invited and made aware of that presentation. And so if they weren't able to join, which often they aren't, they would be able to access a link to where they can listen to that presentation, and it could be useful to them, obviously, as they work with some of the patients that have some of those conditions that Lauren was presenting about. Also, we were able to hear from the senior manager at the University of Utah Center for Medical Cannabis Research that was just created. Valerie, I'll probably not pronounce his last name correctly, but Onanadu. She is the individual that has been hired by the University of Utah to lead the Center for Cannabis Research Center there at the University of Utah. She was introduced and provided a summary of what that center is looking like right now and what they're working on as they just start to launch that Center for Medical Cannabis Research at the University of Utah. If you're interested, again, you can listen in and hear and view some documents on that public notice website that'll provide more information about that if you're curious. Also at that meeting, Dr. Moss shared highway safety data with the team and discussed needing to integrate CMC cardholder information with the medical examiner information. And there's some potential for some value, we believe, to public health in that. And that was a subject that came up. So those are just some general updates from the Center for Medical Cannabis. Are there any questions?
Will Dr. McKiff's presentation at Parco be publicly available?
Let me confirm. I need to speak with our senior registered nurse about that. I believe so. I just need to confirm that. And once I'll follow up with you about that and let you know to make sure the board and the public is made aware where that is available when it's available.
Thank you.
Rich, as far as the highway study, did they have actual documentation that they presented at the meeting, or was it just more of a verbal presentation?
I was actually out of town, but anybody?
It was a verbal presentation, but Dr. Moss showed data.
Awesome. Thank you.
Yeah. And if you have questions about more about the data, Dr. Moss, we can connect someone with Dr. Moss and he can provide more information about that.
Thanks, Rich.
Okay, that's all.
All right, Dr. Forsythe.
Dr. Brandon Forsythe, Director of the Medical Cannabis Program at Utah Department of Agriculture and Food. We have a couple of software projects ongoing at the moment, with one of them going live this week, and that will affect how the processors, cultivators, and eventually pharmacies will apply for their licenses. We're not expecting any major changes for patients with this, but processors should be aware, or cultivators and processors should be aware of this already, and there might be some small hiccups in the program when we get it going with it, but we're pretty hopeful that it will be a smooth transition for everyone. Additionally, we're working on the inventory control system for the medical cannabis licensees, and that seems to be going well. We're in the middle of sprint 3 right now and on track for an on-time completion. Our vendor is asking to extend the UAT slightly, just to make sure that there's appropriate testing before the system goes live, and we're likely to accept that recommendation. So there could be a slight push to the timeline. We'll also be having the cultivation licenses come up for review at our meeting in December, or for the licensing board with the Utah Department of Agriculture and Food, and we invite all patients engagement in that meeting as well. And that's it.
Brendan, what's the proposed go live date for that licensing software this week?
This week, it'll be on Thursday.
Right. All right, thanks for the update. All right, next item on the agenda is we'll turn it back over to UDAP and Cody James for, actually, excuse me, we'll turn it back over to Rich for a presentation on the HHS's proposed amendments to R 383-1 through 383-15, just as a reminder for everyone. These were we discussed these during the last meeting. We wanted to take the time to be able to review them. I would like to ask the board members, did anybody not have a chance to review the rules, the proposed rules sufficiently before the meeting today? Okay, sounds like everyone did. Rich, go ahead with your presentation.
Yeah, so, R 33-1 through R 383-15. Those all are DHHS rules. None of them, of course, are UDAP rules. And the version that appears in the Utah State Bulletin will become effective at the earliest on October 23rd, which is coming up very soon. So, we did have a public comment hearing, and we just had a few small comments during that. No one voiced opposition to the rules, and so we are going to move forward with ensuring that those rules become effective at the earliest on October 23rd, and will likely be on that day. We're coordinating with our policy coordinator to ensure that happens, because we want them to get into effect. And when they come into effect, we'll ensure that the industry and stakeholders and the board are all made aware. But if there's any additional discussion the board may want to have about that set of filings, then now's the time to share those. Now is an additional time, I guess, to share those. There is no requirement the board vote on rule filings. And in fact, a lot of the filings that we do are non-substantive or just a small word change that still has to be substantive, but isn't really impacting the industry in a major way, right? And then there are those cases where there are substantive changes, but in large part, the filing that will go into effect on October 23rd is not a lot of significant impact. Now, there's a separate filing that we're working on right now, and the purpose of that filing is to reflect the Utah Department of Health and Human Services shift toward losing the responsibility over the medical cannabis pharmacies and pharmacy agents and home delivery couriers and home and courier agents to Department of Agriculture and Food. And so the whole purpose of the filing is to reflect that shift is happening. And that filing will not appear in the Utah State Bulletin until November, and the filing deadline for that is not until November 1st. So we're still ongoing, putting together an internal review of those right now, different levels of review that has to happen in order for those to get filed. But if you're curious about that filing, you're welcome to contact our office. We can share that with you, but there's a summary of those that has been posted in a memo that is available on the public notice website right now for those participating virtually. And board members have a copy of it. It's this document that states October 13th at the top. And the subject is DHHS Center for Medical Cannabis Rule Change Filing, dated October 13th. And it explains the whole purpose of the filing. And if you want me to wait for some of you, if you're trying to find it, I'm happy to do that. But anyway, so these will be released in the Utah State Bulletin. Right now, it's on track to be released on November 15th if all the approvals are received by Health and Ag. And I believe Ag is on track to file as well along with that. So it has to be done together because there's some language, obviously, that is coming from our rule and moving over theirs, and we want to make sure it's coordinated so they become effective and filed on the same day and all that. And so I will not take the time to go through the detail because there's a lot of detail. But the bottom line is if any board member or stakeholder has any questions about the filing of DHHS, about DHHS changes that are being done because of the shift of duties from health to ag, you're welcome to reach out to our office and we can assist you with that. And the best way to do that would be just to contact us at the MCPAB email address at mcpab@utah.gov, and we'd be happy to answer any questions you have about this, the information that's in the memo. Because a lot of it is just a shift of responsibility. I won't take time again to review it, but one item that we're adding that was not in the previous that we are adding is on page 2. There's a description of some of the amended rules. And if you go to R383-1 definitions, there's an adding of a definition of QMP proxy. The QMP proxy is that employee of a medical clinic who has the authority to act on behalf of the QMP and use the electronic verification system and use it only if they're designated by a QMP. But we don't name them in our rules yet. And we know that they, of course, have access to a lot of confidential information about patients that they work with. And they're aware of their treatment records, their conditions, and they often are the ones that touch our system. So we want to make sure we not only have a term that defines who they are, but also indicates that they do have access to patient records, but they also have responsibilities that comes with that access. So we're clarifying what those responsibilities are in R383-2, electronic verification system and inventory control system. And also R383-4, one change we're making there is that we're providing instructions to QMP proxies about applying and renewing their EBS registration. Also, we're adding a section to the R383-2 electronic verification system that is just more specific about requiring that EBS users safeguard their login information. What we found is that it's very easy to share login information, right? I mean, we do that sometimes with our Gmail accounts personally with, a family member, whatever, who we trust. But that it is not an acceptable practice when it comes to getting access to a software that has information that is information about a lot of vulnerable people like patients, right? So we're just being more clear than we were before about the need to safeguard that. It's there already, but we're just making sure it's just more clear. Okay, so that's all I'll do. And then there's actually a rough draft of the rule filings here that our staff put together. And so are there any questions about information provided in the memo as a summary of the upcoming rule filing? And just by way of information, these changes will not go into effect, the ones that are described here in this memo, until January 1st, 2024, in conjunction with the changes that AG has that are forthcoming that we'll share at a later time. Any questions?
I have just kind of a general question with the fact that you guys are going to continue to, regulate, PMPs. Will that include the PIC as well?
Absolutely. In the statute, we do maintain the authority over the what we're called the pharmacy medical providers. And as many of you know, state statute, it does allow for a PMP to be a physician, but no one hires them because they can be more expensive. But also because every pharmacy knows they have to have at least one PIC that is a pharmacist. So there are some responsibilities that a pharmacist in charge or a PIC has to the licensed entity, and AG is taking care of that component. But if there were a PIC that were committing a violation of the cannabis laws, then, and if we had evidence that that specific individual that was registered, that it was truly, they were acting alone and it wasn't the facility that was acting, then it would be DHHS that would take the action to potentially discipline their registration as a PNP. And then potentially also forward that complaint to DOPL, so DOPL can take action against the pharmacist license. Because they're two completely separate license and registrations.
Yeah, you got exactly what I was driving at, which is there, that potential for overlap. It sounds like UDAF will be operational, you'll be more from a license and registration perspective.
Yeah, the bottom line is it's possible for someone to commit a violation on their own without any fault of the facility, right? And we saw that. I worked at DOPL years ago, and sometimes pharmacists would act alone and commit a violation. Other times they would do something that was partly the fault of the facility as well. So it depends on what the evidence showed. Yeah. Good question. Okay.
Any additional questions or discussion from the board? Okay, I think we can move on to the next agenda item, which is Cody James and his presentation on their proposed rule amendments.
Thank you. Cody James, Deputy Director of the Medical Cannabis Industrial Health Division of the Department of Ag and Food. What we did is took a couple of the rules that Rich talked about, the 15 that DHHS has, and combined them into two rules. So Department of Ag and Food will have two new rules. R6840 will be the pharmacy rule, and R6841 will be the courier rules. We combined one, which was their definitions, into just one rule. Overall, there wasn't really any substantive, I'm sorry, I'm struggling with that. At this, with the exception of a couple. For the most part, we took those rules that the HHS has just talked about with even their new changes and just made sure the wording matched there. So we did a little bit of internal comparison and made those changes along with theirs. We also went through and changed any statutes that were referring to DHHS statutes that needed to be referring to Department of Agriculture statutes, made those changes, so change them over the 4-41A. Some changes that are a little bit more in detail is we did remove the wording for educational things because we already have an education rule. They fit better there. They're almost exactly alike. But so the change that we'll make will be in the next rules there, but pretty much the same thing. You don't need to have the same rule twice. One of the other changes to talk about is under R684016. Department of Health and Human Services approved a walk-up window at one of the pharmacies prior to coming over to us. So we have made that change to rules to allow that, and that's just as part of the drive-through and curbside service that was already there in the rules as well. Quickly going through a couple of things. Another change, there's the removal of the business name and logo standards from the rule because they are in statute. Again, no reason to have the same thing mentioned in rules is in statute already. So again, other than that, for the pharmacies, it is just those couple things that make an actual change. The other things are just word for word, with the exception of those numbers referring to statute or other rules. R6841, as I mentioned, is going to be the home delivery and courier rule. That is pretty much word for word what they had in their courier rule. Again, changing from sections of statute 26B to the 4-41A aspect. There is some definitions that were added to that. If I could find that here, just to make sure that it did meet with these requirements on the rules, and to, as we're going through the rules, what they're from. Obviously, when it was under Department of Health and Human Services, when they referred to themselves as department, it was them. We had to go through and make some changes to the department. For our rules would obviously be the Department of Ag and Food. But we did add the following definitions. A card, which is pretty much right out of the statute for 26B, but because it wasn't listed in our statute, we put it in this rule. Courier agent definitions, the department is now the Department of Ag and Food, and the rule will refer to the Department of Health and Human Services as DHHS. We did put a definition for the electronic verification system in there, as well as the inventory control system. Also manifest for documentation that's required to go along with medical cannabis for delivery. And then also medical cannabis for this rule means medical cannabis or medical cannabis devices, the terms are defined in again, the Department of Health and Human Services statute. Other than that, we also added pharmacy agent and pharmacy medical provider or PMP to that. To make sure that we're in line with all aspects of pharmacies as well for the delivery. Beyond that, the changes are just those numbers, 26 changing Department of Health and Human Services new statute, as well as Department of Ag and Foods new statute for numbers to be correct in the rule. Again, other than that, it's just word for word what Department of Health and Human Services have submitted in their rule changes.
Cody, will you remind me again, the first substantive change that you had said? I had a question, but it all went out the window, so hopefully you could refresh me.
I'll try.
I'll remember the question.
The substantive changes, actually, so the couple were that, the educational area.
Oh, yeah, that was one I wanted to ask about. So as it, with DHHS, there was no requirement to get approval from them to host an education event. Is that gonna stay the
That's
same?
gonna stay the same.
So cultivators and processors still have to get the approval of you all to host an educational event, include turning in the material that we wouldn't have to as a pharmacy.
Correct.
Okay. Any other discussion or questions from the board? Okay, I think we can move on to the next agenda item. When will this be published in the bulletin?
Yeah, it was on the same thought.
Perfect.
So we have just submitted those this week, and so it should be in that bulletin on November 1st. Giving us that time frame to be in effect by January 1st.
And then do you guys plan to host a public comment meeting like DHHS did for theirs? Or
No, based on what the changes for theirs, they're all comments, so there'll be that 30 days public comment period that's there for the change, but because those changes have already been taught and discussed. Okay.
And we scheduled a public hearing just in case there were questions, because there are other things we're changing it. But, now I believe the actual state bulletin publishing date is the 15th of November. The final deadline is the 1st, and then actually publishes to the.
So ours will be in the previous bulletin, but.
Oh,
Also be in the first.
Hold on, it's being effective.
oh, right, okay,
If that's the way that.
yes, that can work,
Yeah,
that
we
makes
have
sense.
it till February.
Yes,
So it should be fine, even though we did publish
Okay.
yesterday, so.
great.
okay, well, it looks like we're on to item number, I believe, 7 on the agenda, which is the UDAP intro of fee changes for lab testing and applications. Did everybody on the board have a chance to review the documentation that Abby sent out on that? Okay, I'll turn it over to you for your presentation. Ms. Henderson.
Okay, Melanie Henderson, I'm the Director of Finance of the Department of Agriculture and Food. We have requested some fee changes that we're presenting here. They're color coded just to give some generalities to it. The first ones that are all in orange are considered new fees. However, they're new fees to the Department of Agriculture and Food. They are not new fees to the program. They are coming over directly from what was charged from Department of Health and Human Services previously. But we are required to request them since they're new to our agency. So you'll see those to be the same, basically a zero increase for the pharmacy licenses, urban and rural, the courier home delivery license fee, and the establishment license change of ownership, as well as the change of fee. In blue, there is basically, it's not a new fee. All it is it's combining. We used to have 4 different fees that were all application fees. We decided that it made sense. It costs about the same amount to do it regardless of the type for cultivator, processor, pharmacy, and laboratory. So what we decided to do was to request to combine those into just one fee and help simplify our fee schedule a little bit. And then the ones in yellow are all increased fees. The first one is the only one that's not related to, the laboratory fees. So the first one is, the establishment license application fee for level 2. Basically, what we did is we, separated them into application fees for level 1 for cultivator, process for pharmacy and laboratory, and level 2 for courier, home and delivery. The previous fee that, again, this came over from Department of Health and Human Services, was 125. That is not, as we've done some calculations and analysis, enough to cover the costs of the work through this, and so we are proposing to increase it to $250. And then the remaining, you can read through the different types of laboratory tests that get done in the medical cannabis program. As you can imagine, our costs are increasing as everything is, our cost of labor, our cost of supplies. So, we've made an estimate, of 10% for both labor and supplies that have increased. And proposing to increase them by 10% for the remaining ones. And then the last page, is just ones that we're proposing to remove, but those are essentially the ones that are just being combined under the one, license application fee. Are there any questions?
Questions. Under the description and calculation for both the level 1 and level 2 application fees, I see a current expense. One's 200 and one's 100. Can you help me understand what that means, current expense?
Yeah, so we lump our costs into those categories you see, and so that's why it shows up there. So we have our personnel, it's basically our labor, our fringe, all of that goes into that. We have some travel expenses to get to where we need to, and then the current expense, just how our financial system works, kind of lumps everything else into that current expense. So that's gonna be supplies, it's gonna be even some of our, maybe our.
Facility space or
Yeah.
telephones.
Cell phones, data processing, those types of things, everything else just falls into that.
Okay, that's helpful. Maybe another question. I see that the total approximate costs on both of those, not particularly matching what the proposed fees are. Can you help me understand a little bit why those are off?
Yeah, so we're required to report to the legislature how we're estimating these costs. And so this is basically what we've got from last year's data and what we've estimated it at. They're a little bit, they're never going to be perfect. And so some of that plays into there's going to be expected increases, some expected changes in those. We hate to estimate too much, and so we give you what we know. And so that's what the actual costs were in fiscal year 23.
Okay. And then the 10% increase on those remaining. When was the last time these were increased, and how did that number estimate come about?
Yeah, so these get evaluated every year. There's such a fluctuation in the cost of supplies, and especially during COVID, the cost of supplies were going up. So we have, and I don't know if I know exactly for each of those. I don't know if you know, Brandon.
I do. So we set all of those at the very outset of the program and have not increased them since then.
Okay.
We've really worked hard to keep those prices consistent. There's just a point at which solvents especially have gone up significantly, as well as personnel costs.
Brandon, I mean, trying to remember, I think these fees were reduced at the beginning of this, was it the beginning of this year? There was a reduction in fees at one time.
I believe the only one that changed was the cannabinoid test. It went from the 120 down to 130, and that was based on the amount, the total load of samples coming into the lab.
Okay. Probably going back up a little bit higher than it was.
There was a slight change because of the way that the fees are being charged as panels rather than individually, but that was it. And it was just that cannabinoid test that was being discounted. we were getting high enough volume of them and it made sense to charge less. We really try to keep these fees matching the actual cost that it tries to do the testing. And we have to be careful of that, especially because we do have a third-party laboratory and we don't want to charge so little that it makes it impossible for them to run their business successfully either. Absolutely.
Do you know what that volume number is on the cannabinoid testing between a high and a low?
I could give it to you.
Okay.
We don't have that number because we also do cannabinoid testing for hemp products.
Yeah.
And so that factors into it, and it's been like a roller coaster since we just also implemented required testing for hemp products for cannabinoid by our lab, because the test results we were getting were so inconsistent for outside laboratories.
As you'd have done an analysis, just kind of where current testing numbers are, the number of tests being conducted, every year, what this will mean for producers in terms of the additional cost, for producers. Of course, we understand as costs go up, you all have to stay in business just like we do, but just wondering from our perspective, what we might see in terms of additional costs, whether by operator or just in the aggregate, what these new numbers will represent an additional cost for us.
No, we haven't done that. We can look into it though. It should be fairly easy for operators to calculate on their own.
Just wondered if you had done it yourself, because if you knew off the top of your head, so.
Now, one other question, this is, is there, it hasn't really happened a lot, but we are starting to see, through the Medical Cannabis Establishment Production Licensing Committee, there's people coming up they've applied, they never pay, and then they extend again. Is there a relicensing fee that's being charged for the amount of work to cover this? They're continuing to extend their application, never actually paying?
Matt, I didn't clarify your question, I'm sure, Jess. So you're asking for, if there's gonna be a fee for people that extend.
Their approval.
We haven't thought about that on really the
I
overall.
just say your calculations are gonna be off for certain companies that continue to
So
extend.
right now, they're not being charged for a second application fee.
Okay.
Once you submit your one application fee, that's what, unless you're changing that significantly for a different thing, so
Okay.
we're just using that for the time that it takes to go through all the processes, whether they get in licensed in the timeframe. Right, it's the most recent one, it's not something that we thought about a whole lot, other than a couple of check-ins during the year, so it wasn't a whole lot of expenditure after that.
Yeah.
Application came in.
Okay, thank you.
You guys plan to use any of the, the additional, revenue, or not really revenue, but the additional money that's paid into you all to work on any of the testing delays? I know a number of operators have experienced that, or apart from that, what are you all doing to try to assist with some of those testing delay issues?
Yeah, the current testing delays are caused by APR's fee. They recognized that they were unable to adequately test pesticides and mycotoxins. And so they've been needing to ship portions of each sample that are going to them to our laboratory to do that testing. They are getting close to being back online. We've been in constant contact with them, getting updates, and they are really close to being back online. Unfortunately, there's not a lot we can do to accelerate that timeline. They are an independent company, but they have been working faithfully to get that back up and running. We don't really have the ability to ship those costs anywhere else, because it does cost us to run those samples at our laboratory, just like it does them. A significant portion of that, especially for pesticides and mycotoxins, is that instrumentation. It's a very expensive instrument.
You guys get many inquiries from labs, in other states about trying to locate here and bring more labs in?
We've had a couple over the years, but they're honestly not very interested just because of the low number of samples. It would be really questionable use of resources on their end.
Any further questions from the board or discussion?
I guess, do you have any, I know that, I'm assuming that all of the money from, purchasing cannabis, because this is a revenue neutral program, is going back into an account. Can you show that there's been like a depreciation of what you guys need to have in there, that would cause you guys to need to raise these 10%?
I mean, we can show that our costs have increased over this time period.
Do you know how much within that account that these fees and stuff are going into that, like, that you, is there an amount that you guys like to see in there?
We currently don't have anything in the fund that or no, we did roll 20,000, right?
Into which fund?
The one
For the
for
lab
replacing
equipment?
laboratory.
Yes, we put $20,000, we had excess for them to allow them to.
Excess from the cannabis program from somewhere else?
Yeah, from testing cannabis.
It was outside of cannabis.
Oh, okay.
And so that pretty much comes out to like, if you were to raise it 10%, then you would not need to do that again, but it wouldn't have, you wouldn't have like
Well,
extra.
we technically need to be rolling money into that fund every single year in order to replace a large piece of instrumentation when it needs to be replaced. And so far, at the rates we've been charging, we haven't been able to add money to that laboratory fund yet.
I like to see numbers that like say, hey, this is where we're at, this is where we want to be, and this is, you know, if we raise it 10%, this is, will get us back to where we are. So, I mean, we can all agree that with inflation, everything has gone up, but I would love numbers.
We can certainly look at.
If
providing
there's any kind of,
I mean, that's one reason why I was asking about where
Yeah.
that 10% came from when you last changed it. I was looking at the CPI index, that's usually a good indicator of where, and if you look at over the last 3 years, you're gonna be more than 10%.
Yeah.
Now, but that did raise an interesting question for me is, these funds are being used for capital equipment purchases if a fund balance is available.
A portion of it, we also have to pay salaries for the
Right,
lab techs and for consumables in the lab, so.
so there is a desire though to build a fund bank in which you can make capital
Yeah.
equipment purchases. And if there isn't funds available, that'd be a legislative request, I mentioned at that point.
Or from the
yeah,
program.
but it has to come from the program in this case, but yeah, we just, I mean, that's one of our biggest hurdles is patient cost. And I know every
Yeah.
single one of these dollars is ending up, you know, covered by patients. And so if there's anything else we can do, if there's, I'm sure there's not excess money unless magically there is, but if there's anything else we can do, or just making sure that before we vote on this, knowing that it's going to affect patients, that we have adequate data to say this is going directly or back into cost for the program.
Good, JD. And one thing to keep in mind, so the department or the Brandon at the lab has been over the years trying to look at ways to minimize things. One of the things that at the beginning of the program was required was that flower leaving a cultivator had to be tested. Right, so that they removed that requirement to try and lower costs and things like that. So there was a number at the time, probably was a huge amount just because the program's still growing. But there was that time that we dropped that requirement to get flower tested until it becomes a final product. So there's been a drop in revenue coming in at that time, but not enough. I don't think that's a major concern, but just that's how we've looked at it in the past, is trying to lower that
Yeah.
best we can, while still maintaining safety.
Yeah. It's, I think you guys are showing the two sides of this argument very clearly, you know. One, worried about, do we have the money to keep the program running, and two, are we keeping it cheap for patients, and we are affordable for patients, not cheap.
Yeah.
Affordable.
We're constantly having that battle at UDAP internally, like we are trying to keep prices as low as possible. And we've tried to, for up to this point, even lowering at some points, as Matt pointed out, it's just, we really don't have any choice but to increase it at this point.
Can we hear anything from industry if they want to about just what the cost would, how that would affect your business, or? I know just hearing, and I guess even hearing from industry about like the tags, right? Like each tag is so many dollars, and then it's not reusable, and that increases their fees, you know, just those couple dollars, you know, $1 million a year. So
Well,
something
no,
like
we
that.
did get rid of the tax.
Yeah, I mean, I can speak industry, I mean, again, it's gonna be an added cost. Regardless of how you do it, I think, but I mean, working with Brandon in the state, I mean, there's a lot of things they've done. To in order to, we can do bulk testing on items, and then there's a finished product test. Now, I mean, obviously, the goal would be to get lower finished product testing, because that would be more affordable to patients to pass on the savings. Bulk testing allows us to do, I mean, higher limits. So if like an example is just a concentrate, we can do that in an amount of 4 kilos at a time, as high as that. And that 4 kilos can be used for a lot of different items, depending on the products we're pushing out. Or it can be used for one item, depending for making a large production run. But at the end of the day, I mean, again, it's gonna be exactly what it is. It's a 10% increase across the board. So it's pretty easy to calculate that will end up being.
I really don't want to be defensive at all. Because I do understand that these costs get passed on to patients. But we really have worked hard to keep these as low as possible, and I think our track record will show that.
Yep.
Has there been any discussion about, you know, how you did away with the bulk testing for flour, bulk testing for concentrates or anything like that, or would that create a real significant, you know, financial kind of, you know, downturn for you all, and it's just adding to the issue to where you just have final product testing, you know, for concentrated products and not that bulk testing, kind of like with flour, right, where there was gonna be a bulk testing requirement, and now it's just, you know, final product, is that?
The bulk testing actually brings costs down significantly on products, like otherwise doing the full panel testing on every single product would significantly increase the number of tests that need to take place. Additionally, it would actually decrease patient safety and transparency in the industry in general, because you are able to, I don't know how complex the science we need to get into here, but the testing matrix, the composition of the sample really does affect how easily you can find a contaminant there. So the more complex it is, the more sugar and other things that you've added into the recipe, the harder it is to find an individual pesticide or something. So we really have structured it, one, to optimize transparency in the industry and patient safety, but also cost of the industry. A lot of cost gone into this.
Yeah, and I want to jump back to. Okay, maybe I have one more question for you. We're not gonna have a lot on the next one because it's gonna be taken over, so don't worry about it. My last question is, so, oh, I think I'm fine. Oh, no, actually, I did one, yeah, now I remember. So talking about trying to bring more labs to the state, right? Can you give a number, just an estimate, you know, back in the napkin math of how many tests are performed every single year by the program, you know, between you and APRC?
I couldn't right off the top of my head, but I can get you that number. APRC does the majority of the testing, so we don't necessarily see representative number come through our lab.
Okay, sounds good. Any further discussion?
I guess I gotta go back to this capital equipment purchase. I'm a little concerned that you may not have the funds necessary to do those purchases. Typically, you would see maybe like an allocation covered in this current expense or some sort of piece that's being set aside for a capital purchase. Can you help me understand a little bit of maybe what the demands will be ongoing from a 20,000 foot level, and what would be strategies in order to fund those?
Yeah, so.
That $20,000 is not specific to cannabis.
Yeah, that's just general.
Okay, so we actually do have projections out to plan for capital expenses and.
Okay.
We look at the overall fund balance, what our expected revenues are, we project it out for the next 3 to 4 years. What our projected expenses are, we've got these two IT systems that we're trying to implement, which are costly, and so we have all these things and on whatever equipment supplies are needed for the lab, we maintain that. As far as we do servicing on that, we have service contracts for them to keep them going as long as possible. So we do have that data to justify where we're going with the, you know, we're doing the best we can with the funds we have and trying to keep those fees as low as we can.
I was just hopeful that there is a plan in place for replacement when that happens, so that there's not a one-time hit.
There is, we have
That's helpful.
a budget for medical cannabis that can also be used towards laboratory. We just don't have the money set aside specifically in the laboratory fund right now.
Gotcha.
But the goal is to build that up over time.
Okay, thank you.
JD, I can give you some rough numbers from August on the number of quality insurance tests we like there. And we'll be doing our annual report in about a month anyway, so we'll have updated numbers. As of August 3rd, there was 2,824 QA samples conducted. So that was combined with both labs.
Excellent. Okay, any further discussion? We don't have this scheduled for any type of, you know, board action. So any further discussion or questions?
No, I think let's
Okay.
discuss.
we'll go ahead and move on to item number 8. I'll let Trevor speak here in a second, but we do not have the tax commission here today to provide that kind of updated presentation that they had talked about from last month. I do know that they've been having, they've been kind of slow to get some of the information they need to try to figure out exactly what the credit should look like. I was hopeful they would be here today to at least present to us what the cost of decoupling would be, but they haven't. So hopefully, from what I understand, that information will be available, or at least they'll be prepared to present, sometime early in November. So we may have to call an impromptu 1-hour meeting to go over that. I do know in talking with Jason from the tax commission that he's really understanding now the difference between, what the 280E burden is for production versus retail, right? And he really is hoping to hopefully get us some type of credit that recognizes the difference between those. The credit may apply differently or be a different, amount in terms of a percentage for a processor versus the cultivator versus the pharmacy. So I think he's really trying to get it as close to what a normal deduction would look like for us as operators, but he's just not here today. So I would entertain a motion to table, kind of further discussion and decision until we can get there. Look, ultimately, I think we will be told the costs of decoupling. Personally, and from the folks I've spoken with, decoupling is the route to go. It's the route that many states have gone, but Utah faces some unique challenges in that regard, according to what we've heard from the tax commission. So I'm hopeful that the credit that they're going to present will essentially mirror decoupling, if we can't do that right now, and hopefully decoupling will be where we ultimately get to. And I'll just say this, if the federal government would do either reschedule or deschedule, as I would personally prefer, this would all be taken care of. So hopefully at some point it'll become a moot point, but we will probably have to have an impromptu meeting sometime in early November prior to interim to give our recommendation. I'm hoping we can give as specific as a recommendation as possible, as to what the credit should be. So it's essentially just plugging it in, to the bill. So I would entertain a motion to table, or, happy to make it myself. So
Move to table item number 8 until Utah Tax Commission is ready to present.
do we have a second?
Second it.
All right, Abby, would you take a roll call vote, please?
J.D. Larissa.
Yes.
Matt Page.
Nay,
Nanette Riley.
Sorry.
tabling this.
Tabling, yeah.
Des.
Yes.
Annalise.
Yes.
Ken Anderson.
Yes.
Jimmy Higgs. And Missy Smith.
Yes.
All right, looks like the motion passes with only one dissenting vote. All right, we will now turn our attention to item number 9, which is medical cannabis processor delivery, and I'll turn it over to Trevor for his presentation.
Thank you, Chair. So this memo was released at your last meeting. However, since then I've revised it. I hope board members and the public have been able to read through this memo and understand processor delivery as it's been understood in the previous months. However, I'd like to recognize that Des Hennessy has provided an alternate plan, which was available at the last meeting. However, I stuck it in the memo. That was the revision I made. So if you turn to the second to last page in the revised memo regarding medical cannabis processor delivery, that is a quick summary of the alternate plan. It's also available in your packets. It should be there. But the 4 main bullet points that Des has proposed in Utah Patients Coalition, I should say, is to allow processors to establish a website much like a pharmacy that would only be accessible to patients, where patients may see what kind of products that processor is creating and where those products are going, so they know which pharmacies to contact to get delivery from, etc. So we would need to permit processors to list their products, and Des mentioned potential benefits of those products so patients can steer towards whatever they would prefer for their condition. We would need to enable processors to inform patients through their website or through subscribed email notifications. Again, hopefully that would be only for patients. So perhaps with their patient ID, they'd be able to log into the website to be able to see what products are available and where they're going. And then the final part of her plan was to allow patients to request a certain product and have the processor deliver that to the pharmacy in a small batch order. But there are some questions around that I've listed here as well on the second page and the last page, which mainly center around transparency and pricing. If the patient's requesting a product, the processor has to drive that product over to that pharmacy. What's the added cost there? Should there be any restrictions or transparent upfront pricing? But with that, I'm happy to explain the memo further, or talk about processor delivery as it stands, or turn it over to Des to speak more to her proposal.
Does anyone have any questions for Trevor?
I personally like the idea. I think it's fantastic. So
Came up with it.
And I would actually like to mention on that note, Utah Cannabis Association also sent a position letter against the idea of processor delivery, but endorsing some form, coincidentally, of Des's proposal on the last page. It talks about allowing processors to directly inform consenting patients about product availability. But there is a concern that, and both position letters state this, there is no cap on the number of processors in Utah. So regardless if it's processor delivery or this alternative proposal, a potential cap, which you did discuss at your strategy session back in August, it is, I think, on our next agenda in November, but a conversation around a potential processor cap is probably warranted to ensure protection of the market and that we don't have out-of-state folks coming in should the board decide to make a recommendation to regulate that.
You guys want to add anything to what Trevor presented?
well, one thing that I think that should be noted is that the lawmakers are moving towards a type of a model that allows processors to have a website or to be able to educate, to show where their product is going anyway. And so while I would like to pretend I'm a genius, that part was already in play. So that's something that processors have been complaining about. Patients have been complaining about not being able to find product if the processor does not have their own specific pharmacy. So that's already going to be worked through. So really the only addition for what we can expect to be added to the law this year, the proposed law this year is to allow education. But again, I think they were going to add that anyway, and the request of a product. I've talked to some of the pharmacies and they have, and they can correct me if I'm wrong, but they feel like having these small batch orders, it's not going to drive up costs too much to be able to, drive a small batch order, especially if the patient is consistently ordering every month like they do a regular medication. They can plan on sending that when they're going and kind of make it more mainstream in their deliveries. So, with that, I think that we can realize that this is a part of the program that is changing anyway. I think what we don't have, but more mirrors a medical program, is the ability to request. So if I wanted a product from a processor and I know that I need it every single month, now I can get on their website and I can request it, even to a pharmacy that doesn't normally carry it.
I mean, question on that. What is, I mean, so who's requesting? The patient's requesting a product. The pharmacy then has to fill that order with the processor.
They can, I mean, I'm free market and this is.
Because right now, what we're seeing is, I mean, there's no limit. I mean, we're free, you say we're free market. I mean, there's pharmacies not ordering products right now.
Yeah, but.
So are they gonna order one bag of gummies for one patient? Cause we're talking about costs. That cost for one patient to get delivered one bag from one processor is not gonna be, well, I mean, theoretically, it's not gonna be cheap.
Right,
So,
most or some are already doing, they're already driving to pharmacies, right? They're already getting product.
with a patient,
No, the processor to the pharmacy.
I don't think that's
that's,
necessarily
that's
true.
not true.
Can you identify for me how many processors are being shut out of pharmacies currently?
A lot of them.
Yes.
Okay, a lot is, I need a number, right? Like how many actual processors producing products in Utah, independent processors, not vertically integrated processors, who are not having their products purchased at all in any amount by any price?
All I can tell you is that I have patients that say that they cannot find product from certain processors, even if it's like highly specific. Yeah, sorry.
I can give you 5 processors that are being shut out.
I was saying, I can concur for.
Yeah, just wanted a number, not saying whether it's rightful or wrongful, just wanting a number, right? Saying a lot, a lot can be 3 to some people, a lot can be 20, right? So just trying to get an idea.
Well, and you put that in perspective. Now, not all of those, to your point, are vertically, some of them may have a pharmacy. And so they're being shut out. Some may not, some may be the independent processors that they're being shut out. Whether it's patient access we're talking through, at the end of the day, the only people suffering in this are patients, because again, it's their choice in medicine. They should be able to choose what works best for them. They're being told, sorry, you can't have this one, but go ahead and try this product.
But that's not the issue we're talking about.
Yeah, no, and so, well, that's where this, from what I'm reading, from what the Utah Patient Association has said in their letter, I'm just going off their letter, is the point they're addressing is that we want all these processors to be able to get their product to whichever pharmacy will sell it regardless of the order or not.
If a patient needs a specific product, I don't think their barrier to get that should be a pharmacy. I feel like those should be the people that are facilitating, and if they don't want to carry product, what I ask the pharmacies, why aren't you carrying a specific product? Some of them was a money issue, some of it was they couldn't sell the product, some of it was just a bad, business deals gone bad. And if they don't want, I don't want to force anybody to buy product that they don't feel like they can sell. But if they have a product that comes with a patient's ID number that says, hey, this patient is going to come pick this up, we let the pharmacy set the price of which they had to, purchase the product. Maybe it would be a little bit more expensive, but is that patient going to pay that in gas? I don't know. Those are all details that we work out as we, grind the sausage, as they say. So what I'm coming up with is a basic foundation of, let's not have pharmacies be the barrier. If a patient needs a product that they know is available, and maybe if they lived in a different part of the state, they could easily pick up and they know it would help their condition. Let's not have pharmacies be the last hurdle in order to get that. So it's very common in a pharmacy to have a product that you need ordered and sent to that pharmacy in your name. And I'm just trying to mirror the medical model there. Rich, I can't call on you, but I can pretend to.
We're just deliberating. I don't want to interrupt.
And I'm not sure it's
Some
done.
really good help.
I'm not sure we're done deliberating.
Yeah. Just one of the things I think should be considered as a major factor is the complexity of determining the end cost is a paramount question, because delivery is not cheap, especially when it's one item, right? So that's just one question. And who would determine that end cost? Would it be determined in law? What would a particular processors or retail pharmacies cost be determined, be limited in some way or not? I don't know. If it's not, then processors and the pharmacy could add quite a bit up, and maybe that would impact the patient's choice. And maybe initially, yeah, they want this product, but I don't want it at that price. Look at, here's another similar product over at Olson Co. that is a lot, is a lot cheaper, but I want this one. I don't want that one, right? Also, there's another factor would be the argument of, well, pharmacy A, that is the one that is the the retail location, they have a comparable product. And so the argument would be, well, why don't you just buy the comparable? Because we have the same gummy and it has the same milligram ratio of THC to CBD. Why don't you just buy that? Well, no, this one is the one that works for me, right? And it's a good point, right? We don't know for whatever reason, the studies aren't there, but one may work for one person, not for the other, right? So there would just be this, I suppose, obligation of filling it, no matter if that pharmacy has a comparable product or not, doesn't matter. That is no factor. And also, the pharmacy would have to fill it regardless of whether or not, this is a question, would the pharmacy have to fill it regardless whether or not they deliver? There's a lot of pharmacies that do not deliver. But they do accept deliveries from processors or from other processors, right? Because maybe they do some of the work and the next one does a little bit more. I don't know how common that is, but it happens, right? So anyway, there's just some that don't have those those systems set up already, like other pharmacies do, like, you know, Dragonfly and Postal, everybody knows, yeah, they have some systems in place for delivery, but these other pharmacies don't. So it would cost them a lot more money to deliver something. And maybe more than a delivery, it's like a pickup from a pharmacy location, right?
Well, I wasn't thinking that we were gonna force pharmacies into then delivering that to patients, more like a drop-down menu. This is the product you want. What pharmacies can you send it to and pick up at? Now, if
Right,
they pick Wholesome or Dragonfly, there's a really good chance that they'll get delivery as well.
yeah. And then also just another factor to consider in all this, this is why we're here, is to put
No,
some
yeah,
wrenches in this, right? So another would be, well, what's to stop a processor from coordinating with patients in the industry to just order stuff, just to create a demand that's not real, but it's within the QMP of that particular patient, it's within that recommendation to order that particular product, but it's not a true order. It's really just a processor trying to make a point and force the pharmacy to have to make that product available at their location. And so there could be some manipulation done easily,
Always.
because there's so many patients, we've got over 72,000. And there's a lot of employees that also have cards. I'd say if we ran that number, you'd probably find most of them already have cards.
Mhm.
And so it would, I think, be easy to manipulate and use the system, but if they want to manipulate that way, then I suppose we could just let them, and that's their choice to waste their money and
Go pick up
get
the
and order
product.
the product that happens to be, the QMP lets it happen. You know, we see, we can see that happen, I think. I would think it'd just be easy to manipulate and not have it be true medical need. It's just a competitor need to make a point about a particular product and how often that product is requested specifically.
Yeah.
Opposed to legitimate requests.
Well, so, but you're saying they would manipulate the system, but yet then pick up the product, which is one thing, but if we have patients that aren't manipulating the system and are trying to pick up product and they do,
We want to make it
Really-
easy for them.
anybody can do whatever crappy things they want to do. That's not for me to fix. What I'm trying to fix is the patients that have need. And if somebody wants to manipulate the system and pick up extra product, then I guess that's a hobby that they can have, you know?
Yeah, and so those are just some factors I think are important for people to consider as this is considered.
Yeah. And again, I made this proposal knowing that you kind of throw out a foundation and let everybody pick it apart. And so I'm expecting that to happen. Do know that there's some people online wanting to make a comment about this. I don't know when we can allow them to, but so please pick it apart. What I'm trying to say is, we know that the part where processors are going to be allowed, or we're working towards a model where processors are going to be allowed to at least tell patients where their product is and what products they have is something that the lawmakers are looking at doing. So all I'm really asking is to add the ability, if a pharmacy agrees and the processor agrees, to send small batch orders if at the request of the patient, even if it's just for a hobby. Hobbies are good. I don't have many. But in the end, how does that solve the delivery? How does that solve the delivery? Wasn't the main point is getting more delivery to patients? Well, isn't that the point? No, the point is being able, so yes, there's multiple. So one of it is that, yes, that they want it delivered. But we can't, like, I want my groceries delivered from the grocery store next to my house. They don't deliver, so I have to go pick it up. So that's just kind of life. I get what it is, because when I had to drive over an hour to our closest pharmacy, right? We're hoping that pharmacies will get enticed into a delivery model. The fees that are in place for them to be able to deliver, I talked to a lot of them, it is not, they usually go in the hole for delivery. And so they have to accept a model in which they're willing to go in the hole. I know Wholesome is our biggest deliverer, and you're not making a killing on delivery. You guys do it as a service to patients, is my understanding in delivery. So asking them to take another hit and deliver isn't something that we can do as a board. We can hope. So what I was trying to do is get the medication as close to the patients as we could get legally with creating rule.
The question I have on that, I'm sorry. If the goal is to get the products closer to the patients, why don't we visit increasing number of pharmacies across the state of Utah?
I think we will.
And I think the department does that every single year in an analysis.
Well,
I
right.
imagine they're planning to do that again this year, correct, Brandon?
Correct.
Well, I think as an advisory board, we advise the working governance group and the legislators. Right now, there's nothing in statute for an additional pharmacy.
But they can evaluate it anytime and issue a license.
Nothing requiring that there be an
Yeah.
additional one issued, but there's the possibility of that.
Oh, yeah.
We could
Yeah, that's
put-
always there.
We could put an additional license in Tremont. That's not gonna help anybody in St. George.
And also it's often not feasible
Right.
for a legitimate operating
In a rural.
brick and mortar
Yeah.
pharmacy to open up in a rural area.
If I can clarify one point, though, the pharmacy number is capped in statute right now.
Yeah.
So we could not just elect to add another
I
pharmacy.
thought you could
No, you
reevaluate.
can,
You can.
We
you
can
can.
recommend, but I think that.
It's still
it's-
capped at 15.
you just have to explain it to the lawmakers why
But
it's.
then they have to change the number in statute.
No, we took that out.
Oh,
It's,
That's kind of like the initial number, just kind of like with, like cultivation provides, 8 to 15. This says 15, but you can go above
Cameras,
the
all
15 during
yours.
statute.
and it gives certain criteria.
yeah.
And we can talk about it more later, but one of the things that is true is that the economics of opening up in a rural area
It's not.
where it's difficult to get access are really challenging.
Rich,
So
do you have delivery numbers on what percentage are actually going to a rural area?
I do, I'll make sure the board gets that. I couldn't tell you right now off the top of my head. But Trevor might be able to get that info from our data analyst quickly.
Yeah.
And we'll check on that. That's a good.
Also important to keep in mind too, that you have far less patients in rural areas. So of course, it will be skewed to your populous areas of the state, right? You know what I mean? So I think it's just important to keep that in mind. Is there anybody else on the board that would like to discuss either Dez's proposal or the general concept of process or home delivery before we turn it over to public comment? I know we have some folks online as well.
I had a question, and it's more just seeking clarification. I'm all for accessibility. However, it has to be done in as responsible manner as possible. And when I say that, I hold the interaction with the pharmacist very important. And what I want to understand is in any of these mechanisms that we're considering, when is the patient pharmacist interaction going to occur?
So that was also Vickers's concern, when I talked to him. So when I kind of wrote this
That's his,
proposal,
excuse me for interrupting, that's his general concern.
that's his, gen-
Processor,
right,
home delivery, not Dez's necessarily for
Right.
proposal, because we're talking about, Missy, to just kind of speak to your point, we're talking about in some ways two separate things here that are related,
Absolutely.
right? We're talking about the concept of should processors be allowed to home deliver their products directly to patients, basically direct to consumer, right, direct to patient. And then we have what Dez is proposing, which would not allow that, but would make some concessions to processors and to patients to allow patients to get, ostensibly those same products that they would be able to get directly from a processor. So make sure we understand that there are two things at play here. And so I think what Misty is addressing, Misty, correct me if I'm wrong, is more so this concept of processor, true processor home delivery and some concerns she may have around, that as an access point, maybe not necessarily, to your point,
yeah.
yes.
And Missy, so JD's really good at clarifying what I'm saying. He's been doing it for years, but when in talking to people, that was one of the things, and that also brings up another point. If processors were willing to deliver, if they were willing to deliver to my house up in cash, right? Then I can also assume that they'd be willing to deliver to the closest pharmacy next to me at a reasonable cost. And then, at that point, I could have an interaction with the pharmacist that I would not have, if we just did processor delivery.
Well,
So kind of
Well,
two birds, one stone.
another
Volume.
concern,
I mean, they gotta, to make it worth it for them, they gotta have volume.
yeah,
Right, but
They
if,
won't have volume in a onesie twosie.
but if
type
they
of
were
operation.
willing, if they were willing to deliver, if the processor delivery model was to go through, then that shows that they were willing to deliver out to me. So taking it just to the pharmacy is actually probably 20 minutes closer to any of them than it would be coming straight to my house. And then I get the interaction with the pharmacist.
well, and to answer your question, Misty, as a processor, I mean, currently, under rule, you only have really one interaction with the pharmacist, and that's your first appointment.
Correct.
You're meeting with them. I mean, there are pharmacies that are actively continuing to meet with patients. But I mean, I can't speak to all pharmacies, but I would have said to guess that people who are ordering a couple times a month online, they're probably not meeting with that pharmacist.
No.
Again, so having those interactions really at that point doesn't matter whether it came from a processor delivery or it came from a pharmacy delivery, because you're still not meeting with pharmacists. Now, I mean, speaking by myself, I mean, I think you need to be having those interactions. I mean, that is vital for an industry that is medical, but if you don't have access or a close pharmacy to get to, or timing, there's a lot of things that play into that. Then that's another conversation we probably need to be having and how to fix that.
And I should say that we also knew that was the intent, is to always have an interaction with a pharmacist like you do at a pharmacy. Every time I leave the pharmacy, they're like, hey, do you have any questions? That was always the intent with this law. When we moved away from that, it was kind of by accident, and they are reinstating that is the plan this year. So that's also going to be expected again. And so again, we're just kind of trying to move with that model of what is going to be expected and making additions so patients can get product.
That
Well, I
brings
can
up,
speak for pharmacies there. I'm not aware of it. Go ahead.
no, go ahead, you go.
Go ahead.
That just brings up a lot of concern, because I do not ever see a pharmacist when I go into a pharmacy or when I have delivery. So I've seen one initially when I've gone into every dispensary I've been in, which has been 6 in this.
Is that by choice, or would you rather? See?
By choice, I don't need their guidance, I don't need their input, but I understand it's a requirement. But that's the same thing I do when I go to a doctor and he gives me a prescription and everything goes great. I go back in a year and I get another prescription.
Right,
So.
Yeah.
yeah,
It's
and
not,
I think part of the intent of the policy is make sure that when the beginning of someone's participation in the program starts, that they have that meeting. And then have the option later on that they know who to call, or they know where to go, and they know when they go there or call there, they'll always be able to get in touch with the pharmacist. If they're not available, they'll be able to schedule a time when they would be. And that way they can talk to somebody that knows the product, the individual product that's been processed typically by that pharmacy in a vertically integrated situation, but sometimes not, because sometimes it's independently processed. But the expectation is that they will know the product pretty well. And that they'll be able to help and guide as much as possible based on their clinical knowledge, but
There is one dispensary that has a lot of interface, and that's because they have their pharmacists checking in patients,
yeah.
and I have noticed that.
And in like a smaller operation, that's more possible. In a bigger operation, that
Right,
has a
yeah.
lot more volume coming through,
Some or
that's not as possible,
Dragonfly.
but still, my understanding is the purpose is to just make sure that that initial's in place and then ongoing is available if requested.
right.
And then, but I believe that there's a possibility that the law may change in the future, that it'll require that there be at least on every like in-person experience, that there be a question of, do you want to talk to the pharmacist? Or if it's virtual or online, that question be documented. And that's at least what you may
Yeah, I
know more
think
than I have.
I think what they want is, and again, this was I'm just going to kind of regurgitate one small piece of a conversation, but just basically that when you leave the pharmacy, at any time, the pharmacist, even at mine, like he'll stick his head out the window and he's like, hey, do you have any questions? And then at that point, I can say yes or no. If it's online, I at least get a message. I don't use a pharmacy online, but for the cannabis program, I would at least get a message that says, hey, do you have any questions?
Sure.
And so then at this point, we can say yes or no. But there is that interaction and that option to say, hey, yeah, I've been using this, 5 milligram gummy and now I can't wake up in the morning. I'm really tired. Like, and then, hey, do you want to try this? So it just is creating that opportunity and a link in which that they can have a conversation. I think that's all we're expecting.
Yeah, so those are some examples, I think, about touch points.
Yeah.
That will continue in the program, no matter what,
Well, I guess they haven't been.
regardless of what happens with process or delivery or.
Yeah.
this
That's something that
alternative.
we're putting back in. I guess it was
Yeah.
in, I don't know when it actually got removed. But they're putting that back in.
Yeah, I think part of it is like clarifying intent.
Yeah.
Because I think the intent was there, just the language didn't match what the intent was
Right.
potentially. So now it's just emphasizing.
Yep.
This is gonna happen. It'll be a resource to patients ongoing, so. I think that addresses what Misty was wanting to ensure.
Sorry, Misty, we went on a tangent.
No, that's all right. I want pharmacists to be involved in the conversation. And not just during the initial, but I know, speaking from my own personal experience, my medications change regularly, as a individual with a chronic health condition. And, so I'm always interested in making sure that my potential drug-drug interactions are addressed with the pharmacist, because oftentimes it's the pharmacist that catches those things, not necessarily the other medical providers. So especially with the cannabinoids that, quite frankly, interact with a lot of different things, this is going to be an important point. And it may be a fluid point, because every time you add in a different therapeutic, you have a potential for an interaction. So it really can't be a one and done pharmacist conversation. It may be completely independent of the cannabinoids. It might be because of whatever heart medication you're taking, cholesterol medication you're taking, anything else. So.
Yeah, and I think maybe just making sure that we educate patients always that if their medications change, please talk to not only your regular pharmacy, but your cannabis pharmacist as well.
Yeah, I mean, and to be clear, this option has been available, right? At our pharmacy, we have 2 pharmacists on staff at all times. We have 1 doing consultations, 1 verifying orders, and we also provide, as other pharmacists probably know, we provide online telehealth consultations as well. Many other pharmacies take advantage of the services, that we provide in that regard. So it's available, right? I understand the idea of wanting to ask that, question before they leave. But I think we need to bring it back to what it is that we're really talking about here, right? Which is access. And are we talking about industry access? Because the folks that I've spoken to, the pharmacists, the pharmacies that I've spoken to, I've met with now 10 of the 15 total pharmacies. The 4 Curaleaf pharmacies, I've had a harder time meeting with their pharmacists in charge. And short of the 1 pharmacy in Cedar City, I've not heard a lot of general support for process or home delivery. One of the things that Misty brought up, is some of the concern about the touch points with pharmacists. There's also concerns that we do not allow other, providers of medicine, especially Schedule I controlled substances. We can debate whether cannabis should be a Schedule I substance, but it currently is, right? And they have concerns about that being able to be delivered directly to a consumer, in a true medical, a medical program. Allowing processors delivery brings up the concept of, is that just become a closed door pharmacy, right? So there's a lot of concerns that have been voiced to me by pharmacy operators. Another thing is we have to keep in mind that pharmacies are at the biggest peril when it comes to 280E, right? Becoming profitable as a pharmacy operator, I know there are a lot of opinions on this, is very, very difficult with 280E. You can be a very good business and be multiple millions of dollars to the good, and when Uncle Sam comes knocking, he's gonna take 70% off the top. It's just a fact for all of us. I would love to be able to give all of this medicine away for free and treat this stuff just like we treat tomatoes. That's not the way the program's constructed. That's not the way the law is currently, right? So we have to keep in mind that if we are to give processors the ability to do this, what does that then do to the pharmacies? The pharmacies that this program has been built around, the brick and mortar, the rural pharmacies, probably even more so than the urban pharmacies, what's that gonna do to them, right? So while this seems like it may solve something for, 1, 2, 3, 4 processors, and I'm 100%, sympathetic to that plight as the pharmacy representative on this board, I think we have to think long and hard about whether that is the right way to necessarily do this. Maybe it's through more pharmacies, like Matt just mentioned. Maybe it's through the way Des is talking about allowing patients to make, individual orders. Maybe it's through the idea of delivery depots. I know that idea has been explored before. There are many different ways that we might do this, but I really got to think if it's patient access that we're going for here, what has been proposed to this point and what I've seen in HB 72 is much more about vendor access. Now that is a conversation we can have, but that's just the way that I've seen it. And I'll just say the pharmacy representatives, 9 of the 10 that I've spoken to, voiced significant concerns about profits for home delivery, and we're not in support of it. So that's what I can say from the pharmacy representatives. So happy to hear from anyone else, on the board, but I know there are many people in the room as well as online that I think want to make comment here, so. Okay, I guess we can take public comment. Anyone in the room, it looks like Alyssa Snells was the only one that signed up to comment on this. Is there anyone else that would like to comment on processor delivery? Okay, we'll recognize Alyssa first since she signed up, and then we'll kind of go one by one through the room, and then we'll take the online comments.
Elizabeth Reynolds, Utah Cannabis Association. I think I've gotten the chance to speak with most of the board members about this issue from the association's perspective, and I think Des's proposal brings up a lot of the questions that we've had internally as we discussed this. I think we're trying to figure out what processor home delivery is trying to solve for. Is it the accessibility between operators, or is it accessibility for patients? Is it the delivery piece like Nanette said? And so I think that was one of the things that we really wanted to work through, have you guys work through, so that we could understand what we're trying to focus on. The way that it stood in statute last year, as I said in our letter, it wasn't defined enough for us to be supportive of it. And so at this point, I just appreciate the conversation. I think that we're moving in the right direction. I do support patient accessibility. I think it just needs to be done in a way that is feasible and, just reasonable. So anyway, that's all I have to say about this.
It's talking with my pharmacy. I was just taking notes. I'm gonna jump back a couple things. Rich made a comment earlier about generic versus generic. If someone wants product A and it's not available, pharmacy could recommend product B. While this brings the argument of generic versus, if someone wants a 1-1 gummy and they want this, at the core, a 1-1 gummy from another manufacturer would accommodate a similar need. So I see that being viewed as like a generic versus a name brand. There are minor nuances in there where somebody wants to get a heck of this brand, but we're looking at it as medicine at the core, as long as the comparable alternative actually meets the need of the patient, we shouldn't be compromising patient needs. If they want a 1-1 gummy and I only have a THC gummy and we're recommending that, then yes, that's not operating in my integrity. There may be added costs dictated by a pharmacy if we do small one-off orders. So right now, we do a pretty good cadence of getting products in stock, bi-monthly. If we do a one-off order, just being devil's advocate, there is typically a dedicated inventory individual at the pharmacy level, so that's gonna take time to intake the product, receive the product, inventory the product. So there may be an added cost because there's additional personnel that actually have to process that product, so it'd be in the pharmacy's best interest to do, as Des mentioned, a smaller order, not a one-off, but maybe like a 10 or a 20. As a retailer, you also have to be mindful of those patients actually coming through and picking that order up. So we experience a lot of times when a patient places an online order for pickup, a certain percentage at the end of the day, we place it back in because something happens. A patient changes their mind, the patient can't come in. So what burden are we putting on the retailer if we are saying, okay, patient requests product A from a processor, it gets delivered to pharmacy B, and then the patient never comes and picks it up. Now that pharmacy has outlaid time, effort, energy to stock a product that isn't selling. I don't have a solution for that. I'm just trying to talk through some challenges that we may not see here, as we're not all operating within pharmacy.
Your 2 minutes is up. Do you need any of them?
No, thank you. Rather than thank you.
Trying to enforce it a little bit.
No.
This time, nothing.
Throw the hammer down. Huh?
Got the special thing
When can we ask them questions about their comments?
Okay, my name is
Before they sit
Cindy
down.
Mateo. I've been a retail pharmacist and traditional pharmacist for 20 years, and cannabis pharmacist in charge for the last 3 years in Utah. My professional opinion, direct processor delivery, I do not support, and most pharmacists share a very similar sentiment. Processor delivery would be the equivalent of a drug company being able to ship directly to a patient, circumventing pharmacist interactions and checks and balances that are necessary in our medical system. Direct delivery is not allowed in traditional pharmacy retail settings. The pharmacist's job is to review and oversee orders, provide very unbiased recommendations. The pharmacist that would be employed by a processor would be biased to recommend the products that they carry. So I strongly urge this body to prevent such interaction in our program. The intent of the program is to be very medical, and doing this direct processor delivery would be degrees away from an adult use market. I do have support with Des's idea of allowing the processors to advertise to patients and patients to submit requests. That's very important. And that communication, patients need to know what's out there and what's being produced by different processors. But I think the pharmacists in the one-on-one interactions are very beneficial. And it is incorrect to say that there's only one touch point in the pharmacist. For certain people, there may be, but there's some people I see every 2 weeks. I'm always available to talk to them and do many follow-up consultations. I spend many time with these patients. So I hope we can conserve that pharmacist.
Thanks, Cindy.
Just a reminder for those speaking, if you could speak loudly so that I can hear you.
Oh, no problem over here.
Yeah.
Narrative Dragonfly, thank you, Mindy, because I didn't know how I was gonna talk about that for 2 minutes, so I got other things that I could talk about, but definitely echo her sentiments from a concern of direct-to-consumer model. I can only imagine if Purdue Pharmaceuticals was allowed to deliver direct-to-consumer. So I think the real issue that we really talk about here is supply and demand, right? And the supply and demand problem, there's no doubt that there is artificial supply and demand being created by either a choice of pharmacies choosing not to carry certain products that are either low in demand, or perhaps bad operators that from a patient first perspective, you want to work with quality operators that show up when they do and when they don't. So there's a number of reasons why there could be artificial demand that's created. But the reality is the FDA allows infomercials for drugs that are indications from the FDA to be allowed to market those drugs, right? Similar to the state has also recognized certain qualifying conditions that medical cannabis is suitable for. So using that analogy, a processor should have the ability to communicate the benefits of their drug. If it's state sanctioned and approved by the state, they should be able to do those things to at least allow fair supply and demand. People can have access, and right now it's not. The power and control is in the pharmacy, because they're the only ones that can talk about products, put products on their website. So if someone chooses not to have it, that processor is SOL, period. So if we're talking about free market and free demand, processors should have the ability to talk about their products, because there's no way for a patient to be able to find that information if a pharmacy also chooses to just show one image of a product and not actually put the product description. Processors don't have the ability to dictate how a pharmacy displays or represents their products. So it does give unfair advantages to the pharmacy, but I think that solution is easily addressed by allowing processors to have a website that people can actually find information, see products, ask questions, put in requests. Thank you.
Thanks, Mary. Anyone else in the room that'd like to speak to this issue?
Yeah. My name is Nicholas Thompson Law. I'm from MCPAB, we're one of the biggest medical cannabis companies in the state, from St. George all the way up to Logan. I would like to see more pharmacy access. Like, we have 29 counties in the state, there's only 15 pharmacies. I feel like there should be a pharmacy in every county, and there should be more patient access. And I come from a long retail background, and even at one point, I was a dirty car salesman, all into that, but in the day, any car sales company would say, you know, I've got this car, you want this car. I think that pharmacies should have some mechanism of action where they can trade medicines back and forth. If a patient wants 5 of this gummy and another patient wants 4 of this cartridge, those pharmacies should be able to trade back and forth. And maybe that would help some of the supply problems, but I can tell you from coming from a physician's office, we have patients constantly who say, I finally find a product that works really well for me, and then I can't find it for X amount of time. And at the end of the day, it doesn't matter who made it, there should be more education materials coming from those processors. Patients, just like it's been commented multiple times, they go to one pharmacist in many cases ever. And I would advocate that maybe there should be something that, just like when a patient goes to Walmart, the pharmacist comes around, hey, you bought this medication before, this is what's in it. Maybe they can give them some materials from that processor that says, this is what a 1-to-1-to-1 is. That's what that actually means. Or, hey, you know, this is what live resin is. This is how they formulated this product. It's, you know, done this way, or it's ethanol extracted, or it's CO2 extracted, and educate patients better. And so I'd like to see more access to patients and more just education across them. Thank you.
Thank you. Anybody else in the room? Do we have any hands raised online? Okay, we'll recognize Jay for 2 minutes. Please introduce yourself and if you're affiliated with anyone.
All right. My name is Justin Ariola. I'm with Life Elevated Processing. We're the Heal You brand. Just a couple of things. From a business standpoint, me being able to deliver directly to patients would be better than being controlled by business decisions from pharmacy to pharmacy. But that being said, I'm not sure that that's the best way to approach our market here in Utah, because the licenses are open-ended. That would allow a bunch of MSMs to come in and kind of use that as a way to get their products into the market and, you know, provide less control to the state over what type of products are being made available, more leaning more towards the recreational market. Now, that being said, when we talk about pharmacies offering a product that they would say is similar to a particular product in a single molecule pharmacy model, where we're talking about hydrocodone or something like that, that makes sense. In this model in cannabis, a gummy is not a gummy. Some people use full spectrum oils, some use distillates. There are minor cannabinoids that are present in some that aren't in others. And so allowing the patient to be able to choose the specific gummy manufacturer that they would like to receive product from is important. And I will tell you that I have been impacted by some of the recent conglomeration of pharmacies. Now that Curaleaf has bought up 4 pharmacies, we have 4 pharmacies that we no longer are selling product in. And I have a ton of patients who are requesting to have products back in those pharmacies who contact us directly. And so it would be nice for us to be able to just be able to notify patients of delivery, just the active patient list that's controlled by the state of Utah, and just say, hey, here's where we're doing deliveries this week or next week. That would be extremely helpful for patients who are looking for our products.
Thanks, Justin. Anyone else online?
Yeah, Chris.
Yeah. Go ahead, Chris.
Hi, guys. Chris Jeffrey with Wholesome Co. So going off what Nerith said, I think this centers around providing processors the ability to communicate, market to consumers. We would go as far as to say that we could create an ordering mechanism or button on processors' menus, or the processor itself could pick and choose and say, hey, these are the 3 stores that my product's carried at, and then click a link to actually place an order on that pharmacy's website. And so I think that's where this kind of centers on, that starts there. I think once you get that set up, the next step for this would be to allow one-off orders, because you have to batch a number of orders from a processor delivering to a pharmacy in 1 week per se. You can't do the one-off thing. It doesn't work. And so I think that the way we do this is we open up what you guys have already done, the ability to have processors market and communicate with their consumers. Step 2 there is to allow ordering, kind of what I call affiliate ordering. So you can put buttons on the pharmacies that carry those products and kind of route that demand to the pharmacies that are carrying that product. And obviously, if the processor does a great job marketing and communicating their products, and the efficacy of the product is at a certain level, I think you're going to create that demand, and then pharmacies will end up carrying that product. So I think we're on the right path here. I think the only thing that Des recommended that we haven't figured out quite yet, is the one-off order that comes in through the pharmacy. But I think it starts first with processors sending demand into the pharmacy. That will open up enough volume on a weekly basis per se, and then you could open up the one-off orders. So I appreciate you guys hearing me out there.
Thanks, Chris. Anyone else? Okay, bring it back to the board for further discussion. If any, if not, we can take action. I mean, we can take action to either just, not recommend that it moves forward with processor home delivery. We can take action to recommend that we move forward, and recommend, essentially some of what Des is saying, and we work towards that position. But happy to hear any further discussion at this point if there is any. All right.
Yeah, I was gonna say, I don't have much more discussion. I just want to make sure what the action request is for today, and have we properly noticed the alternative proposal? So could we take action on that today? I guess the question.
I believe so.
Okay.
And it was proposed as before the last meeting. We didn't get to it, and it's also been proposed, prior to this meeting, including the materials that have been made available to the public. So yeah, we are able to take action on either the general concept of processor home delivery, or kind of this other avenue that we've been talking about that wouldn't allow direct processor delivery, but would open up marketing, kind of these either one-off orders or however we get there. So I mean, I think we're able to take action on either or both of those things.
Excellent.
I mean, in perspective there, I mean, if we're gonna address marketing zone, that's a statute change that has to be addressed. I mean, that's one vote. The other one is then allowing processors to have a website that can actually, I mean, if that's kind of looking at the Utah Patient Association's request, right? I mean, are we wanting to lump all this into one giant vote? Or is it segmenting it into certain sections we agree upon? Because we're gonna have to draft certain language to legislators saying, as a board, here's what we feel that the direction should be, rather than looking at specific processor delivery.
Yeah, I guess that's the first question.
Yeah.
Do we want to take a general vote on up or down for processor home delivery as it's been presented in HB 72? Because that's really all the more that's been presented, in general, right? And we want to take that vote. And if we don't want to address that vote, then the question is, what votes do we need to take to recommend maybe some of these other things, processor marketing, websites and education and different things and one-off orders. We could break those up individually, but I think the first question is, do we want to hold a vote on processor delivery generally? Because that's really what the discussion is, right? I mean, that's what we've done. So, happy to take a motion on that, and then depending on how that motion, plays out, we can get to maybe some of this, some of this additional, business, so.
And just a suggestion, I think whoever would make a motion, they would want to make sure that they specify the detail of that when they make it. And if they need help with that, get help as you do it, and it's okay to need to get that detail, but I like tying it, if there's a motion, if you were to tie it back to the actual legislation. So it's specific, because that makes it specific, that sharpens it, so everybody knows, oh, okay, they would support that, or they support that an original concept, that helps. With
Certainly, I mean,
communicating
that's the
information
only,
later.
that's the only thing we've been given to this point on process home delivery is what appeared in HB 72. There's, any other, limits or things that we put around it, guardrails or anything, those would have to be, that'd have to be something additional. So I think all we've seen to this point is what HB 72 says. So we would want to tie the vote to the language as it was proposed in HB 72. I think they had some changes in the first and second substitute.
Yeah.
I would say second.
Second
That was the
substitute,
final,
right?
because it was
Yeah.
step 3 that passed.
Yeah.
And as a public, you can't ask a clarifying question at any time.
I mean,
Even though this is a clarifying.
yes, you're welcome to ask a clarifying question.
Clarifying question, so are the marketing pieces that doesn't mention already in motion, because that would be extra to this.
No, there's talks about, moving in that direction, but there's nothing we've seen in any sort of statutory draft or bill draft or anything like that.
We just have.
All we've seen is HB 72.
I was just thinking if that was already in motion, we would need to necessarily address that, since that's not been addressed.
Yeah.
Thank you.
Do you want me to clarify the language from HB 72?
I mean, certainly if you.
So it was a provision allowing a home delivery medical cannabis pharmacy to enter into an agreement with a cannabis processing facility to deliver medical cannabis orders to a patient's address directly from the processing facility.
And there would still be pharmacist review and presence.
Correct.
Whenever there was a transaction happening, it wouldn't be that the pharmacist is not involved at all. Law would require there to be a pharmacist.
In the facility.
Important, yeah, and there were factors brought up by Mindy and others that still with that, there's concern.
Yeah.
About what bias they may have as a pharmacist, but anyway, that summarizes it.
You said something about the partnership with the pharmacy,
An agreement.
an agreement. Okay, does that mean, so that pharmacy's pharmacist would be the one checking off the order?
No,
Or
so
a processor could hire their own pharmacist,
under substitution 1 from HB 72, the processing facility would have to hire
a
a
pharmacist.
separate pharmacist in order to verify orders.
No, there was.
Or they
one
could hire the
pharmacist.
same one,
They,
Yeah,
you
you could hire
do
a pharmacist could be hired to be a freelancing pharmacist.
Exactly.
Cannabis industry.
they could sell like that.
Sounds like a cheap way to get product to patients, that's the case. But
The job.
it's not.
What it really is.
So. That's all about it. Thank you, Trevor.
Okay, well, I think it's time to take action, so happy to entertain a motion on the concept of, processor delivery. One way or the other, either a motion to recommend that we approve the language as set forth in HB 72, or a recommendation that we do not approve, the language as written in HB 72. Because I think until we get past that, we're, that's the elephant in the room for now, so.
I will go ahead and make a motion that we do not approve the languages set in HB 72.
Do we have a second? Second. Okay, we have a second. Abby, will you take the roll call vote, please?
JD Rosen,
Yay.
Matt Page,
Nay.
Nana Durante.
Nay.
Desiree Hensey,
Yay.
Annalise Key,
Sorry, I want to make sure that I'm voting. So I would like to not have processor delivery. Is that yay or nay?
Yay.
Okay.
Same thing I had to do.
Yeah,
I
we all
this in
had
my
to
head.
Kent Anderson,
Yeah,
Jimmy Higgs,
I believe Jimmy had to log off. Oh, there he is.
Yay.
and Misty Smith.
Yay.
Okay, the motion passes with 2 dissenting. Okay, now if we wanted to go into some of the, the more detailed, things that we'd like to support or not support, happy to entertain individual motions on those as well.
Okay, so I'm gonna get to the summary of my proposed thing. So, so do you want us to just start like, because we have basically if we go off of his summary, we have the ability to allow processors to establish websites accessible only to registered patients. So do you want to make a motion on that and then we
Yeah,
vote
I
on
think
that?
we
Just start picking for those.
That's the right down the list.
Rich, does that sound?
Unless we.
I mean, I'd be comfortable with the 3 marketing being put into one motion.
Yeah, we don't need to.
Yeah, why don't we do websites, whatever, yeah. if we could
Information
Group them
efficiency.
together,
Product education and lists and I mean,
Or do we just feel comfortable voting on Dez's proposal in general?
do we know what the current language is as far as like with pharmacies? Is it specific to targeted marketing?
For pharmacies, I believe
Is
so.
that the language that's written? in there?
Targeted marketing is.
There's a definition of targeted
There is.
marketing that relates to pharmacy operations, what they can do,
Okay.
and
I just,
for targeted marketing. And it requires that there be consent from
What, do you remember what bill targeted marketing was in?
It requires consent, it requires.
Consent.
In a medical card holder.
yeah,
And inside our pharmacies, since it's a limited access area, everyone in the card carded. So in the pharmacies,
Yeah.
like external, you have to make sure that they're 21 and an active card. And they're consented. Sorry.
No, it was perfect.
I mean, that means we'd have to change statute because,
oh, yeah.
because we wouldn't be able to card.
All
If
the-
it was
We
a
wouldn't,
website.
we would recommend or advise that
Yeah,
maybe
so I
they.
mean, we need to make sure we include that language in.
In the
there,
motion.
In the motion.
Right, that this is a amendment, proposed amendment, recommended amendment to state statute, yeah. All of what we're talking about, all this is state statute change.
Yeah.
Yeah.
It's 441A-1104, and it does just mention pharmacies in that instance.
So we would just be adding,
Yeah, it would be a different section, Cody, because there's a separate section that relates to.
Establishments and production establishments, which is in the old portion.
Right, but you don't have to have a
61,
citation for
right?
it, you can just support the concept as a board if you
61?
chose to.
Okay.
Right?
Yeah.
One critical factor, I just think it would be important, it's okay, JD, to point out is that, would there ever be a difference in what a medical cannabis pharmacy could advertise and what a processor could advertise? For example, discounts. It doesn't make, I don't think, what's the best way for me to say this? It may not be a good idea to allow a processor to advertise discounts.
well, because the pharmacy can't hold them necessarily if the pharmacy is selling them.
Yeah, but well, there's ways to only allow certain pharmacies to carry your product if they agree to pass on a certain discount or whatever.
Okay.
So you wouldn't allow them to advertise discounts. But the pharmacy can advertise a discount on any product they want in targeted marketing, right? So that's a critical difference, is the law, I believe you may not want to specify, or you may want to specify that a processor would not be able to advertise discounts on the products or in targeted marketing, right? So you wouldn't find discounts, in clearance specials like you would in a targeted marketing email or communication from a pharmacy or retail establishment.
But would there be opportunities for like, say, if they personally had extra of a certain product, could they not say like, hey, we're selling this at a discounted rate to pharmacies right now?
my impression is it should be the role of the pharmacy to do that.
Okay.
But I'm neutral on this, I'm just saying. You may wanna make it the pharmacy's role, so that way it's very clear, because you're kind of creating this little crack in the
I know.
policy, and so it makes an exception for a bunch of processors to make everything fall under, oh, but had an oversupply. Well, most of the time, a lot of times when you have a discount, it's a case of an oversupply. I'm not an expert. I think the industry would be better at explaining this than I would. But that's just one factor I think is important to consider, is how you handle discounts. Any type of a discount,
Yeah,
any like mention of price,
would naturally fall on the pharmacy.
only pharmacies.
Yeah,
So
Now-
specific as this is just product availability. Essentially,
this is product
Right.
availability
that's all it is, it's not.
and requesting.
Right,
Yeah,
and when you do it, you're never doing it publicly. You're never showing an image of a product publicly.
only to your email list or whatever, right?
Yeah, it's
Right.
targeted marketing,
Targeted marketing,
just
yeah.
same as the pharmacies have, it's targeted marketing.
How do your standalone, processors gonna be able just to send it to patients? Because they shouldn't really have a patient list.
Well, I think once patients get on and say, hey, like, they get onto their site, just like a pharmacy, then now they have their email, and do you agree to get emails? And they say yes, if they want targeted marketing.
Riverside will have one person.
Yeah, and maybe it's a discussion for another meeting, but I think one question that needs to be answered is. Should the statute be amended to require that there be a cardholder requirement every time? Or, and what is the responsibility of the processor to verify that? Or is it just that they have to be over a certain age?
What if you force it on the Utah ID to log in? They don't
What's
have
that?
to force their website for credential to log in at MJ, or is it?
Yeah, I don't know if you, just wanna be careful about requiring Utah ID login information.
But
To a website that you're not gonna be ordering anything from, you're just getting advertising information or targeted marketing material from. Because Utah ID has its own set of complications for registering, and people forget their login and passwords, and it gets to be frustrating sometimes for some people that don't log in a lot.
I was thinking that's the one consolidated place to verify.
Sure.
But it would be in the pharmacy's best interest to check if somebody had an active.
Hey, no
card
more conversation with the public for a minute and bring it back to just.
And
Before they received one of these small batch orders, for sure, so
Sure.
are they?
And we're not talking about small batch orders right now, just so you know, my understanding, we're just talking about general target marketing.
Okay.
We can talk about small batch orders
Just general.
later,
target-
as
yeah,
a,
targeted marketing.
yeah.
Annalise has a comment.
Yeah, thanks. And what I want to say as a medical provider is I really like the idea of the websites, but I think it's important that we have some pretty specific parameters in place in terms of, I like the idea of people that only people that have a medical card would be able to access that. I really like the idea of, listing what products are available, potential benefits, but also potential side effects as well. So it's a balanced presentation. But overall, I do think that the idea of a website is a good one.
Yeah, and we do have, with our company, right, with the way our website works, right, you have to sign up, you have to get a profile, all of those things, right, you have to go put your patient information in. The one thing that I think would be, I don't know how others would be able to build this in, but being able to verify that medical card, right, to make sure they're a patient before they can view, some of this information, because it's not hard to put an age date in, right, it's not hard to put a checkbox in, consent to receive, the information, for what we allow generally for targeted marketing. But if what we're really hoping to do is only have this available to medical cannabis patients, there would have to be some verification process to determine that they're actually a medical cannabis, patient. And honestly, I think we'd be happy as a company to offer up our technology capabilities to show people how to automate and to do those checks. So we'd be willing to do that. But yeah, this is exactly the concept, I think, of what we're really going for, is trying to just provide greater just knowledge base and awareness around what products are out there and where they can be found, right? And we really just want to keep that germane to medical cannabis patients. So I think we can agree on that. Like I said, we'd be happy to offer up, and show you how we've done it, with our our website and our technology.
Rich, quick question. So it's kind of, I have two questions, depends on your answer. The EVS website, what is the capability of that as far as adding new functionality?
We are in the process of improving the functionality of it and building it in a way that it's easier in the future for us to make changes to it, so that we can be more nimble in modifying it according to law changes or rule changes.
Yeah, I think.
And ag is on their end doing
Yeah.
the same thing with their side of it with Salesforce.
Okay. Second question here is. The Department of Alcohol and Beverage, I don't know their acronym, right? They currently have a website that you can go in and see every single liquor store across the state, their current inventory, current pricing, alcohol content, whatever it is. Can we, I mean, instead of proposing individual websites, I mean, I think we should do websites still. I think the educational factor is important. But I think what it is we're looking at product availability for patients to know where things are, what they're priced, where they're at. And all that information is housed currently within our inventory control system. Can we not recommend a state webs like through the EVS, so everyone's logging in, there's no external I think it's pricing too. It's not just factors that people want to know what's available.
Yeah.
I think to Desiree's point, we want patients to know the price too, because there is a difference between pharmacies on what a price is being sold for.
Yeah.
So people can know what that's available. They're going through EVS, it's only an EVS. You're 100% verifying that that is a patient. They have their part, it is, I mean, it's active. They can see that list and they can see what pharmacies have at any given time. And maybe there's even a point on there saying, would you like to subscribe to this processor's mailing list? Because then they're opting in through that, they already know they're a patient.
Right.
And then there's no circumventing or anything behind on my own website I have to create.
Yeah.
I was just gonna jump in and say, I think we're to a point where probably inventory is something that with the current system we have, we could probably do something similar to that. If we go any further than that, is maybe this new system we move to, not that ability to do that with some extra stuff that gets added as we go along there, but. We don't really know about our current system, as you all know, that's, probably not without. A lot more money happen, but maybe starting next summer. That's definitely something.
Well, this is gonna be.
Right.
Yeah.
You've got till April till it's signed, and so we got the runway.
Yeah, you just asked about the EVS system, our current one.
Yeah.
The concept you described, though, correct me if I'm wrong, but there's essentially a gate.
Yeah.
That requires Utah ID, you have to be a medical cannabis card holder. What Annalise was explaining earlier that was important to her, right? And it makes sense. And once you get through that gate, you're able to access all the processor information, but without getting through the gate, you can't access it at all.
Correct.
Yeah. So, yeah, that concept is doable. It just would require some additional funding that, we'd have to make a plan if this legislation were to pass, it would require this to be created. And we would work with ag on creating it. And in the future, we would be better at making those changes quicker than we have in the past because of the fact we have more control over how the configuration is done and the timing of it and the priority of it.
Okay, yeah, we've only got about 1 minute left on this issue, I'll recognize. And then we either probably need to make some additional motions, or we're gonna move on to the last issue on the agenda.
That's what I'm trying to move toward, is maybe there's enough nuances here. It's gonna be difficult to make a motion on this item at this point. I'm wondering if maybe Matt or Des could work with staff to come up with some language to come back and.
I was gonna say, we can always take these concepts and flesh them out over time as staff, come back with multiple potential recommendations. And you can approve what you like and trash what you don't. That may be, and especially if we have a meeting in early November on 280E. Perhaps we could extend that as a special session on these two priority items as their priorities for this board and for the legislature.
But one addition to that is it may be important for the board to approve a motion if they support process or the concept of processor targeted marketing in general and advertising. If they're supportive of the concept, make a vote that just says we support the general idea, right?
All right.
And then we can have Trevor send a message from the board to lawmakers that says there is support for this from the board, right?
Yeah.
And we're working on details.
And hopefully before interim's over, we can come back with those details, but yeah, give lawmakers the heads up that there is something in the works.
Yeah, sounds great.
Chair, I'd like to make a motion that we expand the definition of targeted marketing as currently written to allow processors to just include processors. I think that's really what it is, because we're gonna keep everything else the same.
Okay, we have a motion. Do we have a second? Second. All right, we have a second. Abby, will you take the roll call vote, please?
Yes, JD Lorenzen,
Yay.
Matt Page.
Yay.
Nana Brady.
Yay.
Desiree MC.
Yay.
Annalise Key,
Yay.
Kent Anderson,
Yay.
Jimmy Higgs. And Missy Smith.
Yay.
Okay, that motion passes unanimously. All right, we're gonna turn to the last item on our agenda, which is the medical cannabis pharmacy ownership cap. Before I turn it over to Trevor, just to clarify, this is not to cap the number of pharmacy licenses that are available in the state, but to cap the number of pharmacy licenses that an individual business or entity, could own, because there's been some questions about that previously. So with that, Trevor, take it away.
Thank you, Chair. Again, this memo also was available at our last meeting, so I hope everybody has had some time to read it, but to set a little of the stage. We have in Utah 15 pharmacies, and of those 15, they're owned by 8 different entities. Out of these, one entity owns 4 entities own 2, and 3 entities own 1 pharmacy license. So the question has arisen in the legislature if there should be a limit on the amount of pharmacy licenses that one entity or person would be able to own. So on page 3 of this memo, which should be in your packets, you'll see a table of other states, how they have set certain pharmacy ownership caps. Not all these states are medical only, but I did highlight Alabama, Hawaii, and North Dakota as being most similar to us in terms of program structure and how many dispensaries they have. And they have, for example, Alabama and Hawaii have 25% ownership caps. They have 12 and 8 dispensaries respectively. North Dakota has 8 dispensaries with a 50% ownership cap. So the question, which you can see on page 4 here, back in, I believe it was August, the Medical Cannabis Governance Structure Working Group, they solicited input on this issue from the public, and most people said somewhere around 30 to 35%, with one person saying maybe 25%. So I put 4, 5, and 6 licenses of the 15 that are currently in operation and their corresponding percentages in the total ownership. And to add here, last week, that working group met again, and a representative ward of that working group advocated that it should be any number less than 33%, because 33% would be 5 licenses, 1/3 of the total number of licenses. Representative Ward thought that, there should be at least 4 rather than 3 or 2. If there's 3 or 2 as the cap, 33% or 15%, that could offer up some collusion in the market on pricing. So that's a little context for you. One lawmaker has said that they would like to see less than 33%, meaning at the very least 4 different entities owning the various licenses in the state. And then the rest of this memo has a couple arguments for and against. Most of the arguments against a cap is that it would be, government control, artificial government control of the market. But again, most people, both on the lawmaker side and on the industry side, have advocated for some sort of ownership cap. One question that is pretty paramount here is, if the board did want to recommend an ownership cap, it has to consider that, how do I put this? Management agreements and direct control in pharmacies is the idea that even if you don't outright own a pharmacy, or you don't have voting or financial interest in a pharmacy, you could still enter into a management agreement with the pharmacy where you would be directing day-to-day business, right? So if the cap was 1/3, no more than 1/3 of the 15 licenses, and someone reaches 5, what happens if they want to take 49% in a 6th pharmacy? And by extension, once we get to 16 pharmacies, if we go there, would that cap stay at a whole number, like 5 of 15? We would have to get to 18 for 6 of 18, 1/3, right? So the board could consider limiting any sort of voting interest, financial interest, or management agreements in whatever percentage until we get to that whole number. And the language here will be complicated, right? The legislature will have to figure that out. So I'd urge to keep it conceptual, right? That the details will be a little hard in terms of language. But that is definitely something to consider. What limits should the board recommend placing if someone reaches that ownership cap and wants to have additional ownership? And with that, I'm happy to answer more questions or clarify anything, since I know it was a little complicated there at the end.
Yeah, I'm more lost now, thank you.
One idea though is you could think in terms of one option would be, they can't have any.
Right.
Zero.
That's
0
the
to 0,
simple,
and
yeah.
that's simple, right?
So not even
You reach a
1%.
certain percentage, it cannot be any more than that. And if it ever is, you are breaking the law, and it would never be approved.
I mean, that's
If you-
probably the cleanest way to do it.
Right.
I mean, instead of trying to figure out, is it 22% they can have, 49, 46?
Exactly.
You know how it is, because that is what may occur, right? Is, well, I want to get more than, than 5 pharmacies or 4 or 6, or whatever number we decide on. And I think that's the best way to go about it, is you can't have another ownership interest until it gets to be a sufficient number that you can obtain a whole, another pharmacy, right? So right now we have 15, you'll have time for public comment, brother. 15, right? I know you're anxious, I get it, me too. But there's 15 now, right? So if we were to say it has to be a whole number, if you had 5 currently, you couldn't get to 6 until we got to 18. Right? You know what I mean? One thing that we could do to alleviate some of what Ray Ward, Representative Ward's concerns were, and he even, indicated this, is even if we go with 1/3, you would still have to say that there has to be at least 4, owners in the market, right? Or you could even go to 5 if you want to, if you want to change that at all. Just that there would never be able to just be 3, owners in the market if we went with a 1/3. You couldn't ever own more than 1/3. But we'd have to also say that there has to be at least 4 pharmacy owners, right? To make sure that you have that variety of ownership. And look, I think if you go with 1/3, I know that's not Ray Ward's, chosen number, but that would provide 5, right? The pharmacy that owns the most right now is Curaleaf. That would allow them to still get 1 more amongst the current, number of licenses. They would not be able to get to number 6 until we got to 18. That would provide everyone in this room the ability to get between 4 and 3 more, 3 to 4 more. That's the number that seems right. The question just is, I think we're hopefully gonna answer this, is you can only get to 6, once we get to a place where there can truly be 1/3. It's not, well, we went to 16, and now that means you can have 5.4, meaning you could take, a portion of an ownership interest, a 40%, ownership interest in another, in another pharmacy until we get there. I think keeping it as clean as possible is a great way. And I also like the idea of having a living, breathing number like we did for patients, right? You know what I mean? The 1.5%, QMPs can see 1.5% of patients. It's not a stagnant number. It grows as the program grows. We don't have to come back and revisit this, because if we said, hey, 8 licenses is the total you could ever have, well, no one's close to that now, but one day someone gets to 8, you have to come back, and then it's like, well, we go to 9, do we go to 10? I like the idea of a percentage, and then just making it cut and dry, but until you get to the next level that allows you to kind of, I don't know, for lack of a better term, unlock, another pharmacy. That would be it. That seems to be the cleanest, but of course, happy to hear, others, thoughts on this. I mean, the idea is just trying to prevent, a monopoly, right? By 1 or 2 or 3 groups, right? To make sure that there's enough variety so we can continue to meet patient needs and access and all those other things. I know Matt, had some questions that he and I talked about before, if he wants to ask those, but that's kind of the way that I've seen the issue since it was first, brought up, and try to keep it as clean as possible, so we're not having to try to do math on, man, you can have 62.4% of, this pharmacy or the other. I think it just makes it a lot easier for tracking.
And one factor to consider also, I guess, one option additional is recommending that lawmakers amend the law to give ag the authority to set the percentage and rule. If you wanted to give them flexibility, I don't know if ag would like that. I don't support this.
Don't have anything.
Yeah. Anyway, that's always an option if the lawmakers were to agree to trust the state agency in that way. Sometimes they work it out that way, and that makes more flexibility, so you wouldn't have to get the bill passed. And, you lose time during a session, it doesn't pass or something, and then you're stuck if you can't get the bill passed. But allowing it in rule, who knows what'll happen in the market in the future. There may be reasons why you want to give a state agency that authority, or there may be reasons why you don't. So that's up for discussion as well.
Hey, Rich, a couple questions I have is, can you talk to us about when the original RFP came into play for pharmacies back in 2019? There was limitations placed on the industry, say you could only have one rural and one urban, so a total of 2 pharmacies. Where did that come from? And like in statute and things like that, like where, I mean, I've looked through it, I haven't seen it, I just want to know, like, where was that direction and why was that number decided on?
We decided on that just to set some general parameters for the RFP. And that was one of the parameters we set.
Yeah.
And it wasn't based in a specific statute or rule. We have the authority as the state agency responsible for issuing licenses for pharmacies to make tweaks like that, to make conditions. And so we thought, we want to make sure that there's no company that, as this program launches, that has, I get too much control, I guess would be the way to describe it. There wasn't a science to it, but we wanted to make sure they didn't have too much control when we started the pharmacy RFP process, understanding that the market changes over time and our market was unique. And our market may have challenges that other markets in other states may not have, especially at the beginning. And as the market matures, maybe there's some value in doing some consolidations and whatever. So we always knew those limits were specific to the RFP. And we didn't put a time frame on it in statute. Lawmakers didn't put a time frame on it, or didn't even have it in there in the initial launch of the first statute that was in place when we went through that RFP process. So yeah, it was just an interest by us at the state agency to make sure that there wasn't one company that had too much control.
Yeah, well, I mean, speaking through the industry, I mean, obviously, I think when there were changes earlier this year of acquisitions through pharmacies, a lot of people didn't quite understand, well, can they even do that? Because we thought it was 2, it was just, everyone assumed the limit was 2. But obviously that's not how it's written in statute, and so the sale and the transaction went through. We talk about one pharmacy having too much control. And I know a lot of people thrown out this number of like 35%, and I think really the conversation from sitting through those meetings is not because they feel that's a great number. It's because they looked at the current balance of pharmacies and they see, oh, this pharmacy has 4. I think there was a recommendation saying, well, they should be able to expand, so that would give them 5. And then you do the math, and that's how you come up with a number. But wasn't that something that they were dead set on? I think in this last meeting though is Rep. Owens, or Senator Owens he said he was concerned about having 3 pharmacies controlling the entire industry, or 3 businesses, I should say. And so he wanted to see at least 4 in the language somewhere written that way. I mean, I think, when I looked at all these percentages and all these numbers, I think, we talked, Utah is unique. I don't think there isn't anything wrong with us as a policy board, just advising legislators that, if you took that original number that you went through at 2 of the 15, you know, you do the 15, and then it was 14 initially, and that's 14.28%. Let's round up to 15%. I mean, I don't think this specifically we need to say you're limited to 2, but there should be room for growth as pharmacies prove that, you know, they've been able I mean, pharmacies will eventually grow. We're gonna have additional pharmacies in the industry. And we want people to be able to have access to products and it is true that a current pharmacy that has the understanding and the know-how can continue to put on more affordable prices into the market. But so they should be able to expand. And I mean, I just feel kind of on our side, I mean, the more companies there are, the better. When I look at Curaleaf having 4, the downturn in the market and the pricing fluctuations and the changes have all come into place ever since they took control. And to me, just being at 4 already is a concern. So if we're really concerned about patient access and having availability of product they want at affordable prices, I mean, we have to make those hard decisions. And I think, capping at 15%, now what does that do with Curaleaf? I think there's nothing wrong with grandfathering them into where they get rate. You're at 4, you're still at 15%, you have to wait until we get to, I don't even know what that number would be, like 36. So, but at that point, that's fine. And I think that's a play that we can say as a board that we support industry, we support this free market type thing, and we don't want reduced businesses and reduced competition because of one industry or one company already has 4, and that should be a logic. So, thank you.
Any further discussion from the board before we take potential public comment? I'll just say, I think that, you know, grandfathering them in or requiring them to divest, you're gonna have legal issues abound. I'm sorry, at some point, I'm a litigator and I'm a lawyer by trade. It reeks of lawsuits, right? So I know what Matt is trying to say, and I absolutely hear what he's saying. But the practicality of that and what it may mean, very different than just saying you're capped out at 15%. Because, you know, if you grandfather them in, you're gonna have people saying, hey, I can't get to 4, right? You know what I mean? They have 4, so I gotta go buy those pharmacies, but I can't now, right? So I can't do that same thing. And if I'm required to divest, if I'm Curaleaf, I got my law firm on the phone right away, right? So it is a concern, and I think that's part of, you know, that's why there was big concern from many people and why this came up during the session. You know, I was privy to some of those conversations, Alyssa was as well. There was concerns of them buying, you know, trying to buy up the entirety of the market. But now I feel like you're cementing their position as the big dog, right? And I get why you might grandfather them in, right? You know, you might limit others, but I feel like you're in some ways, like, you know, kind of doubling down on the buyout that they had to get to 4. So, you know, I'm not sure there's a great way to do this, but I think if we do try to either grandfather someone in or cap people, you know, and or try to make them divest, I think we're gonna have some significant problems and lawsuits. Now, I know a lawsuit isn't always a reason not to do something or the potential for a lawsuit, but just thought I'd, you know, bring that to bear as, you know, as a former litigator, because I can tell you that it's the first thing I thought of when Matt and I, you know, talked about it, you know, previously. Logistically, what does it then look like, you know, and it's not to try to help Curaleaf out or whatever, it's just the reality of a situation, right? At some point it becomes, you know, litigious, so.
And just to put it on the record, I'm not saying we make them divest. That wasn't why, hopefully you didn't hear that from me.
Right.
I mean, really the thing is I don't think, we shouldn't be in a position ever in Utah to tell a company you can't be in business, you own too many. I mean, we let them get to that point, that's, I mean, the thing is, and there's nothing saying they can't ever grow. And it's just at the current point, the population for patients, it doesn't make it sense to have 36 pharmacies to this date. So.
Any further board discussion? Anybody online? Okay, do we have anyone in the room that would like to comment? Now it's your turn. Now it's your turn, brother.
I just wanted to make a recommendation to look at also limiting related parties. So related parties are, I have a brother and I'm at my cap, whatever we agree on, and then my brother goes and applies for my cousin or whatever. So looking at related parties when we're putting a cap in, because all that is just a lubricant, like,
Yeah.
you know, like a cousin, a brother, somebody, so.
How do we decide like if they're a BFF or an ex?
There needs to be some vetting process, you know, like a BFF isn't a related party, technically a related party typically, I believe is immediate family or, there's a definition, I'm not Merriam-Webster, but.
Yeah, other states have put in definitions like that.
Yeah.
In their limits, and so.
I think we talked about it early on in the program too. where
Yeah.
Steve mentioned, like, we want to look at related parties, so it's not, you're not having a straw man apply as, oh, now I am outside of my allotted allocation, so now I've got Smith, who's actually the second cousin in the application. And then I would also reiterate to Rich's point on the MSA. MSAs are master service agreements, which in the cannabis industry, it's a sale without a sale. So if we limit MSAs, then it would prohibit operators from coming in and operating as if they own it. But on paper, another group owns it, they're just siphoning all the revenue out to another group, so. Payson was an example of one that was under an MSA from another group. And that has then been acquired, so we just want to look at related parties and then. The last thing I just said, whatever. MSAs.
Thank you, John. Anyone else?
Yeah, I'd like to kind of address that. I think from an industry perspective, I think one of the challenges. Oh, sorry, Jared Dragonfly. I think one of the concerns from an industry perspective is that there's a pretty clear difference between the goals and strategies and commitments of local operators versus MSOs. And it's shown through lack of fiduciary responsibility, business practices. I think that's really the greater concern, is that we have people in our state that don't have a vested interest in our state. Their vested interest is in business. So when you talk about that, people are going to make different decisions. So in addition to related parties and things like that, I think if we really want to take care of our program, we should make sure that there's actually locals running our program and people that have clear vested interests in our community. You can argue and say, is that free market or not? But the reality is I think you can go down the list of people who are from Utah, their goals, their missions, their values, and their actions that they actually do for the community. And I think those things matter. I think as a business, not only do you have a fiduciary obligation, but you have a moral obligation to take care of your community and the people that support your business.
Anyone else in the room?
Nick was talking about from Empathetics Medical Clinic. I was gonna say much of what the esteemed gentleman from Dragonfly said, but I would say that coming from a place where before some of those pharmacies got acquired, we were able to work with some of those local pharmacies and help patients get them better access, talk to those pharmacists. If there's issues, we could alleviate them through that. Now that a bigger company owns those pharmacies, there's a brick wall, they won't talk to us. So that doesn't help patients.
Right.
And so I would say maybe there should be a limit cap. And I'm not saying that anybody should be stifled or be available to grow, but maybe 4 should be the number. And some of these other pharmacies should have the ability to grow, and local actors. And a great example would be someone like Bijan's Pharmacy, where we do things to help patients actively. And I don't think it services the community to have out-of-state actors that more focused on profit in many instances, as opposed to taking care of their patients. Thank you.
Thank you.
That's a good point.
And if I could just make a quick comment, one of the things I've noticed as I've followed some of the legislation and lawsuits in other states is that when it comes to giving favor to those that are from within one state and giving license favor for whatever reason, any preference, there are lawsuits. So
Yeah, generally it's found to violate the dormant commerce clause.
Right.
I mentioned that. Any state that's tried it, generally the challenge to it has been has been successful, but that's not lost, you know, your comments, right? Even if we can't do it, your comments are not lost. Okay, look, I mean, we're talking about somewhere either between 26.67% and 33.33%. That's kind of where we are, is the current, you know, cap, right? Where the company that owns the most right now is at 4. That would be 26.67%. And it would cap them now until the program grew by enough, you know, that we could get, you know, essentially to a place where they could still only be 26.67, right? No matter how you chop this up, the numbers are never gonna work unless we set a hard number, which I think we can all agree it's probably not the best way to do it, because we'll have to come back and have this meeting again and again. You know, Cody will have to go to the legislature again
He loves it.
and again. Yeah, do that anyways. But I think just coming with a percentage is a better way to do it. So I think that's kind of probably where we are. I do think if you set it at 4 right now, that would ensure that you have generally, you know, 4 operators, right? You have one that would only be able to have 3 licenses, right? If you chop it up the, you know, the same way. But it would, you know, kind of massage the fears of Representative Ray Ward, which was, I don't just want 3. He said, hey, there at least needs to be 4, you know, available in the market. That would allow any current operator other than Curaleaf to grow by up to 2 pharmacy locations under the current, you know, number of licenses, right? And it would allow others, you know, to grow by up to 3, right? That would provide a lot of growth. And we've been very intentional in Utah about the way we've determined, you know, generally adding more pharmacies, right? You know, it started at 7, you know, then it went to 14. We added another 115 to provide, you know, greater rural access. So I think that the state will likely remain intentional in the way they dole out, you know, pharmacy licenses, you know, with the studies that will be done and things like that. So I don't think it's ever going to say, hey, we're going to add 20 more, and you're all of a sudden going to see the ability for one company to just go hog wild and try to, you know, scoop all of those up. And I don't think that's the way the licenses would be, you know, necessarily reviewed. So that's kind of where I see it with the discussion. If someone feels, you know, otherwise about some different numbers, or if someone wants to argue to 40% or less, you know, happy to do it. But I do think it would be useful to you know, as Matt and I were talking, to recommend a number, right? We could say, hey, we're generally favorable to, you know, license cap, but I don't know if that really gives the legislature much of an idea of where we kind of stand as a board. Look, honestly, Curaleaf has 4 pharmacies. That seems to be the precedent for right now. We feel comfortable with that cap, great. If we want to let them grow by 1 or 2, we could do that as well. But if we want to limit them where they are today and give other businesses the ability to grow into that, even if licenses don't change, right? I mean, even if licenses don't increase, it still gives you the ability to grow as a business.
So would it be better to make the motion that like it's at 33.33% or just keep it at 26? That's where I'm at, is like, do we?
I'm like 30.
Like
Let's just
30,
go with a
let's-
hard number. Let's make it in the middle. I think there's been a lot of comments why, you know, 4 licenses should at least remain. I think there's a lot of good arguments maybe why that shouldn't be increased. So I would lean toward just a 30% cap, including limiting MSAs and related parties as part of that
Is
cap.
that your motion?
And that's,
yeah, you
yeah,
want
go
to,
ahead.
the other part I want to discuss just to make sure of is because this is going to be probably part of that motion is you would have to essentially get to a place where you could own a whole number, right? Like,
Yes,
if that
yes.
30% gave you 4.67, you wouldn't be able to take an ownership interest in something else. So we want to keep that a clean number.
The percent would have to equal a whole number.
Right.
Okay, so you could own no more than 30% of the total available pharmacy licenses. We would limit the ability of MSAs and related parties, and we would also ensure that you could not go to 5 until we got to a true whole number. You couldn't own any ownership interest in a pharmacy until you got to the ability to own a whole pharmacy license. Okay,
that is my motion.
Second.
As board staff, let me ask the board staff, do you feel that there's sufficient clarity in the motion that's been made for you all?
Can you restate it?
So, the percent license would be capped at no more than 30%. That would include a limit to MSAs and related parties. And the 30%, in order to obtain another license, you'd have to reach a whole license number.
Okay, the motion restated. Do we have a second? Okay, the motion's been seconded. Abby, when you get a chance, when you're done typing, you can take the roll call vote, please, unless, Rich, you have a clarifying question?
I'm just emphasizing the fact that we would define, or we would allow the ability to, or leave it up to lawmakers to define related parties how they want it.
100%.
And the industry would like to be a part of that conversation, and the board would like to be a part of that if they want.
Yeah.
Yeah. And then they would maybe define MSA.
Right.
That would be important to do, so yeah, we'll understand that. Yeah, those are just two things to emphasize as we move forward.
This is more of a general recommendation,
Yeah.
but some specifics, but some generals as well.
Yeah,
Hopefully
it
we
gives
can-
lawmakers what they want, though.
Yes,
Right.
yeah. Okay, we have a motion and a second. Abby, will you take the roll call vote, please?
JD Larson,
Yay?
Matt Page,
Nay.
Nanette Redsley. Yay. Desiree Hennessy,
Yay.
Annalise Key,
Yay.
Ken Anderson,
Yay.
Jimmy Higgs,
Yay.
and Missy Smith.
Yay.
Okay, the motion passes with only one in dissent. All right, we do have our next meeting coming up. I'm not sure if we've selected the agenda topics for it. It will be another 3-hour meeting like this. I think he's approved, this today has proved well, because we're actually gonna end on time and maybe even a few minutes early. So hopefully we can keep doing that. Please keep in mind that we may need to call a special meeting, earlier in November. Because currently and we may even need to discuss potentially moving our meeting up for November, because right now it's scheduled for the week of Thanksgiving. So we may just discuss generally moving that up to earlier in the month. It may mean meeting within a couple of weeks of each other. But look for that. We'll have our strategy session on Monday. We'll kind of go through that list of priorities and try to put forth what we think are the next, kind of most pressing issues. But I'm hopeful as we work through the end of this year and into next year, we will get to some of those issues that some of you all brought up. I know that Jimmy had brought some things up to me. Some other folks have brought up some, issues of their own, but I would love to be able to get to at some point. As much as I love to do the work of the lawmakers and regulators, I hope we get to some of our own, agenda items. So be on the lookout for the agenda. We won't set the agenda or send it out until we've gotten some feedback to make sure we're addressing the right things. But hopefully you'll be amenable to maybe moving the meeting up. That might be the best, is instead of meeting twice in November, maybe we just move that meeting up. That might mean that it has to occur that first or second week of November. So I know we'll have to coordinate the schedules. Happy to allow the next meeting to be entirely virtual if we need to accommodate people's, schedules as we get closer to the holidays. So now I will entertain, unless there's anything else, the most popular motion of the day.
Motion to adjourn?
All right.
Second.
Or adjourn. Thanks, everyone.
I thought you were gonna wanna have Thanksgiving with us, JD.
Friendsgiving.
Yeah.
I was gonna make like sweet potatoes.